Our organizing chairs are Dr. Basantara Sarma and Dr. A.K. Grover, sir. Our organizing secretaries are Dr. Ben Limbu and Professor Ghulam Haider, sir. Our guest speaker for tonight is Dr. Norris Joshi, sir. And I, Dr. Prerna Arjal, along with my colleague, Dr. Ashish Rajpant, are moderators of today's webinar. Our organizers are Nepali Society of Oculoplastic Surgeon, Oculoplastic Society of South Asia, and Telangana Institute of Ophthalmology. Now, without doing further delay, I would like to invite Dr. Basantara Sarma, sir, President, Nepali Society of Oculoplastic Surgeon, to give an opening remarks. Sir, the screen is yours.
I think I'll just, someone else is sharing screen. Anyway, can everybody hear me? Okay.
Yes.
So, good afternoon, good evening, everybody. Chairman, sir, members of the organizing committee, distinguished guests, speakers, friends, and colleagues. I feel greatly honored to welcome you all to the first webinar of the Nepali Society for Oculoplastic Surgeons and Oculoplastic Society of South Asia. NESOS was formed in 2014 with just a handful of members, but since its inception, it has grown in stature, and presently we are 31 members strong. Due to various constraints, NESOS holds its national conference every 2 years, and the third national conference was held in 2017. For the last 2 years, the NESOS team has worked very hard to make our fourth national conference in 2020 a grand event, but due to the COVID pandemic, we had to cancel all the programs. Nevertheless, like someone once said, there's no teacher like adversity, and in that spirit, human spirit, webinars have come in as a blessing in disguise. They have provided us with immense opportunities for experts to come together on a common platform, frequently and with relative ease. But more importantly, it provides ophthalmologists from developing countries like ours to learn and interact with international panel of faculties, many of whom are world leaders in their specialties. And lastly, I would like to take this opportunity, and it gives me immense pleasure in taking this occasion to inaugurate the book titled Retinoblastoma in Nepal 2019. The book is edited by Dr. Ben Limbu and supported by his team from NESOS, team members from NESOS. And his team I also like to congratulate his team for successful completion of that study. And finally, we have some good news for our oculoplastic fraternity. Dr. Rohit Saiju, our past and founding president of NESOS, has been recently elected president of Nepal Ophthalmic Society. So I congratulate him, and we look forward to working together with Nepalese Ophthalmic Society and NESOS and OPSSA and other organizations in future, so that in these times, difficult times, we can continue our friendship and our programs together. Thank you all for being here today, and I will ask the moderators to proceed now.
Thank you, sir, for such encouraging words. Now, I'd like to request Dr. A.K. Grover, sir, President, Oculoplasty Society of South Asia, to give the welcome speech. So, the screen is yours.
Thank you, Dr. Prerna. Welcome you all. Good afternoon. This is an occasion which is momentous because we as South Asian countries who have so much in common in terms of our legacy, in terms of our culture, in terms of our shared problems, shared assets, I think it's a great opportunity that we are all getting together in these webinars. So these are planned as a series of quarterly webinars where each of the 4 countries will be hosting them. We have very similar patients, we have very similar problems, and we have very similar resources to handle them. It is therefore only fitting that we should get together. And there is a lot more that we can do together, have fellowships together, have research projects together in the region, that it was only fitting that we formed the Oculoplastic Society of South Asia a couple of years ago with the initiative of our friends from Nepal, Bangladesh, and Pakistan. This has been a very, very nice journey. We have seen over the last 2 or 3 decades how the subspecialties in the region have grown. I was one of the founder members of the Pakistan Oculoplastic Society. I've seen the Nepal Society grow from 1 person to become a huge movement, and I've seen how Bangladesh has grown its oculoplastics work. I was a visitor to Dhaka some decade and a half ago and visited their EPIC center, and I've seen how things have grown from there. So it is heartening to see the growth in the region, and I'm sure working together, we can take it much further nationally, internationally, all over the world. And I'm sure these webinars are a step in the right direction. We hope we can use the template that we have designed with this meeting. We can improve upon it as the time goes, and hopefully we can make these meetings very, very useful for all of us. I'm grateful to the Nepalese Society for the excellent organization that they have done for this meeting, and I look forward to a wonderful meeting. Welcome you all once again on behalf of OPSSA. Thank you.
Thank you, sir, for such a warm welcome. Now, before starting the program, I'd like to introduce our esteemed expert panelists. Let's have a look into our panelists. We are honored to have you all here today. Our first panelist is Padma Shri Professor Dr. A.K. Grover. He is a well-known figure in ophthalmology as well as in oculoplasty. And as he has already said, he has seen the growth of all the Oculoplastic Society of this region. He is a chairman and in the Department of Ophthalmology at Sir Gangaram Hospital and Vision Eye Center. He is the president of South Asian Association of Oculoplastic Reconstructive and Oculofacial Aesthetic Surgery, and he is a past president of OPSSA, OPI, and AOS, and he has numerous awards and various researches in his name. Now, second panelist is Professor Dr. Rohit Sainjusa, and he is a professor and head of Department of Orbit and Oculoplasty at Tilganga Institute of Ophthalmology and Director of Hospital Services at TIO. He is, as Basanta sir has already mentioned, he is a president of Nepal Ophthalmic Society, and he is a founder president of Nepalese Society of Oculoplastic Surgeon. And he is a vice president of OPSSA and OPSSA as well. And he has an advisory board member in NESOS, that is Nepalese Journal of Ophthalmology. Our third panelist today is Dr. Basanta Sharma. He is now president of Nepalese Society of Oculoplastic Surgeon. He is a postdoctoral clinical fellowship done from University of British Columbia, Vancouver, Canada, and he was a former associate professor and chief of oculoplastic services at Lumbini Eye Institute, Sri Ranambika Eye Hospital, Bhairava, Nepal. He is presently a medical director at Sri Badri Eye Center, Bhairava, Nepal. Now I'd like to request Dr. Ashish Rajpant to proceed for the introduction of other panelists and the program ahead. Dr. Ashish, the screen is yours.
Thank you, Dr. Prerna. I am Dr. Ashish Rajpant, oculoplasty surgeon working at Mechi Eye Hospital, Zappa, Nepal, and I am delighted to be a part of this historic event. It's my honor to introduce to you Professor Dr. Tayyab Afghani, who is Professor of Ophthalmology, Director of Projects and Publications, and Head of Department of Orbit and Oculoplasty at Al Shifa Trust Eye Hospitals. He is President of Oculoplastic Society of Pakistan, recipient of Outstanding Services Award for the Prevention of Blindness, Distinguished Services Awards at Asia Pacific Academy of Ophthalmology, and he has an extensive experience in dealing with eye tumors and oculoplastic surgery, as well as wide experience in community ophthalmology. We are honored to have you here, sir. Our next panelist is Professor Dr. Ghulam Haider, sir. He is the professor and head of Department of Oculoplasty at National Institute of Ophthalmology, Dhaka, Bangladesh, and he is lifetime member of All India Ophthalmic Society, Ophthalmological Society of Bangladesh, Bangladesh Medical Association, Asia Pacific Society of Oculoplastic and Ophthalmic Plastic and Reconstructive Surgery, Oculoplastic Surgeons Society of South Asia, and General Secretary of Bangladesh Oculoplastic Surgeons Society. He is also the author of Handbook of Ophthalmology and has contributed many chapters in oculoplasty. He has more than 58 publications and more than 100 presentations at national and international conferences. Thank you for your gracious presence, sir. Our final panelist for today's webinar is Dr. Ben Limbu, who is consultant cataract, ophthalmic plastic and reconstructive surgeon and assistant professor of ophthalmology at Tilganga Institute of Ophthalmology. He is General Secretary of Nepalese Society for Oculoplasty Surgeons. He is Scientific Secretary of Oculoplastic Society of South Asia. He is Editor-in-Chief of Eye Plastics. He is founding co-director and executive director of Working Vision USA, and he is Chief Executive Officer of Global Eye Center Private Limited. It's our pleasure to have you with us, sir. Now, before moving to the scientific sessions, I would like to take you all to the virtual tour of Nepal, which is provided by Nepal 8th Wonder of the World YouTube channel.
Ashish sir, you can select the audio sound now.
Yeah.
The audio is not coming. आशीष सर, आप जब वीडियो शेयर कर रहे हो उसमें ऑडियो सिलेक्ट कीजिए.
Okay. A beautiful place with beautiful persons. Once is not enough. That is naturally Nepal for you. If you like the video, you could watch this and many other excellent videos of Nepal from the YouTube channel, Nepal 8th Wonder of the World. Now, let us move on to the first session of today's program, that is case presentations. Just a little housekeeping before we proceed. A gentle reminder to the presenters, only 8 minutes is allowed for the presentation. There will be a warning bell after 7 minutes, which will signal you to conclude your presentations. Similarly, only 4 minutes are given for the discussion, which will be headed by respected panelists. With this information, I am delighted to introduce Dr. Malita Amatya, who is an oculoplasty surgeon working at Tilganga Institute of Ophthalmology, as our next speaker. Dr. Malita completed her fellowship from Tilganga Institute of Ophthalmology, and she will be speaking on eyelid trauma, fearful to fearless. The screen is yours, Dr. Malita.
Dr. Malita, we can't hear you. Can you unmute yourself?
You can proceed, Dr. Malita.
Am I audible now?
Yes.
Yes, you are audible.
Good afternoon. So I'd like to thank NESOS and OPSSA for giving me this opportunity. And I'm going to present a case, eyelid trauma, and I have no financial disclosures to make. 47-year male from Calcutta who visited Kathmandu for his business trip presented to us 2 days after the fall in the bathroom and trauma to the right eye. On presentation, his both best corrected visual acuity was 6.6, extraocular motility and pupil were within normal limits. On local examination, there were periocular abrasion and ecchymosis, and some scabs, which was in healing stage, was visible. And there was a mild lid edema on the right lower lid. The right lower lid has a lid defect, which is significant, and there is a tissue loss, which is almost half of the lower lid. And there was a conjunctival congestion and the subconjunctival hemorrhage at temporal and inferior limbal region. So his both eyes, cornea, AC, iris, lens, and the posterior segment were within normal limits. And according to the history and clinical examination, we made the diagnosis of a right eye lower lid traumatic lid avulsion. And we planned for the exploration of wound and reconstruction under local anesthesia. Since the patient needed to go back to his city to attend the important meeting, and he did not want to close the eye for a few days after discussing, we discussed with the patient, and so we chose the right lower lid posterior lamellar reconstruction with the free tarsal graft from the left upper eyelid. And after all baseline investigation, surgery was done on the next day. So on the surgical table, the traction suture was given on the right upper lid. The wound was explored, and the necrotic and devitalized tissue were debrided. The residual lid tissues was separated in layers. Both the anterior and posterior lamella was identified, and the dissection of the anterior lamella from the residual posterior lamella was made. So as we planned, we harvest the free tarsal graft from the left eye upper lid, and we took the free tarsal graft of about 8 mm in length and 4 mm in width, and it was transferred to the right lower lid and sutured to the inferior conjunctiva retractor complex with the 6-0 vicryl, and laterally the graft was sutured to the lateral canthal ligament. The anterior lamella was reconstructed with the myocutaneous advancement flap, and the eye was padded for 1 day after application of the antibiotic ointment. And on the first postoperative day, his lid margin was aligned and the flaps and the sutures were intact. Since he needed to attend the important meeting, he left us for his city on the next day and followed up with an oculoplastic surgeon at his place, but he kept contact with us via email, and he was happy and satisfied with the outcome of the surgery. So the general principles for the full thickness eyelid defect, we should recognize the full thickness or partial thickness and always aim to provide the adequate canthal fixation, provide sufficient horizontal and vertical eyelid dimensions to avoid the vertical tensions on the lower eyelid. And we should always try to do the direct closure if possible prior to sizing of a graft, and the tissue match should be as best possible for the grafts and flaps. And the eyelid adequate to avoid the exposure sequence must be in consideration, and the optimal eyelid symmetry and cosmesis in terms of tissue color, texture, and thickness. And here is a table shows the treatment of the full thickness lower eyelid defect. The small size lid defect is reconstructed by direct closure, canthotomy with closure, lateral advancement flap. And if the defect is medium size, then it is reconstructed by lateral advancement flap. And if needed, then the canthal fixation, canalicular reconstruction, and the periosteal flap is added. And for the large defect, it is reconstructed with the lateral advancement flap, huge tarsoconjunctival flap, mustard cheek flaps, and in adjunct full thickness screen graft, autogenous tarsal graft, or the hard palate mucosal graft, and the nasal canthotomy or canthalysis is done. So the take-home message, while repairing the full thickness eyelid defects, it should be repaired in layers always, and first the posterior lamella should be repaired and then the anterior lamella. The direct closure always necessitates first repair of the tarsus with the buried mattress suture, a gray line suture, then the last line suture, and the repair of the anterior lamella. So using the flaps or grafts, one should consider flaps on flaps, graft on flaps, or a flaps on graft, but never graft and graft because of a high chances of a graft failure due to the compromised vascular supply. So I like to request all our distinguished panelists to highlight on the other options for the reconstruction in this case and what could have done better in this case. Thank you. So here is my references, and I'd like to thank and acknowledge my professor, Dr. Rohit Saizu, for this case, and I'd like to thank Dr. Ben Limbu for supporting us, and I wish all happy, very happy Vijaya Dasami, and thank you for kind attention. Thank you.
Thank you for the nice case presentation and brief overview, Dr. Malita. Now I would like to invite Professor Dr. Ghulam Haider sir for expert opinion on this matter. Ghulam Haider sir. Are you there, sir?
Okay. Hello.
You're live, sir. Ghulam Haider sir.
Okay.
We are hearing you.
Do screen sharing, but
So should I answer?
I am not going to have.
Maybe you can open your PowerPoint.
Trying.
Yeah.
PowerPoint is there.
Open it and then once again screen share. Stop screen share. Open PowerPoint, minimize it, keep it on one side, and then start screen share again. Maybe you can discuss without the slides also. We can have a open discussion.
I have. এই আসো তো। তখন কি গেল কোথায় গেল? না আসেন কই গেল?
Please minimize that slide, sir.
Okay. I'm trying. Just with us. Yet na. No. Back karo. এটা।
Sir, can you stop the sharing and first open your PPT and you can share, na?
Okay.
First open your PPT.
Reduce its size and keep it to one side.
Okay, right. Okay now?
Professor Ghulam, you can actually go with the audio. Okay, that's there.
Professor, you can start your video. Your video is off. Can you on your video?
Okay.
Yes, we can hear you now. Yes.
Are you okay?
Please go ahead.
Sir, can you switch on your video? Yes, you can go ahead.
Oxygen. Oh, you're able to.
Share also.
Is it?
And then with the person. And it is.
Okay.
Yes.
Discussion on the case report. Normally, we know that lead construction's basic is that less than 25% lesion direct closure, 50% lesion anatomy with canthalisis, semicircular flap, more than 50% gutter bar, wrist flap, tarsal pedicle flap, and loose positive, a master protection flap. It is normal that doing that like that, but my technique, in case of that presented by the Dr. Malita, I use a new technique, the tail flap like. It is flap like a tail. Length should be double the size of the defect. Incision should start from the lateral canthus. It is obliquely upward and downward laterally. It is wider and gradually narrower. You see the tail flap. The flap is here. Tail flap. 20 mm height. 30 mm length. Down the gap of the length, but my tail flap is that. You see, the 30 mm, 50 mm gap. So we can use the tail flap here instead of use flap. Like Malita using the dorsal plate, straight flap up and it also. Again, on lower lid, 30 mm length. More than half of the, double the size of the defect. You see, advance of the flap. Here we are not using the tarsal plate. First stage and second stage and third stage. So the upper lid same. The photograph preoperative with the masses here. Remove the masses, there's a gap. I show the tail flap. The before surgery, after surgery, by tail flap. Same BCC in the lower lid, remove the lower lid, and using the tail flap, you see the tail flap, and reconstruction of the lower lid, and before surgery, after surgery. Again, the lower lid defect, the core children, and the tail flap, we can repair the lower lid reconstruction, also the upper lid reconstruction, Malika patient have an injury in the lower lid that I'll have. We can repair by this way, by tail flap. Again, for upper reconstruction and coloma, we can use the tail flap here. Same. The new technique, tail flap is a new technique, both upper and lower lid reconstruction. Easier to perform. Learning curve is less time consuming, less complication, and cosmetically more acceptable. And my conclusion is that this is very small series, very demerits compared to tangent flap or huge flap. Study large series of cases required for please a comment. Thank all of you. Hello. Thank you all of you.
Thank you, Dr. Ghulam.
Thank you, sir. Thank you, sir, for the discussion and comments. I would like to remind our audience that if you have any questions regarding the presentations, then please type them by clicking into the question and answer icon in your Zoom control panel. We'll be running live panel discussion session wherein our esteemed panelists will answer your questions at the end of the webinar. Now, without further ado, we'll turn the time over to our next presenter. Let me invite Dr. Om Bahadur Gurung, who is an oculoplasty surgeon at Hetauda Community Eye Hospital, running under Tilganga Institute of Ophthalmology, to present on necrotizing fasciitis, how did we manage? The platform is yours, Dr. Om.
Thank you, Dr. Ashish. Namaste and good evening, my seniors and my colleagues. Today, the topic of my presentation is necrotizing fasciitis. How did we manage? So, no financial disclosures to make, and written informed consent has been taken from the patient for displaying the photographs. So, my patient is a 40 years married female farmer by occupation, and she was referred from another hospital with a painful lid swelling in right eye after lower lid surgery. So there is no significant history of diabetes, hypertension, immunosuppression, or any chronic disease. She is not under any prolonged medication. She is non-smoker and non-alcoholic. She had a history of uneventful right lower lid plication surgery for entropion correction under local anesthesia 4 days ago. So our vitals were stable and systemic examination were non-significant. She was febrile. On local examination of the eye, her vision in the right eye was 160, while in the left eye it was counting finger close to face. Extraocular movement was limited in all gazes in the right eye. In the left eye it was full, but she had exotropia, probably due to adherent glaucoma covering most of the pupil. On coming to the adnexa, she had the tense, tender lid edema extending both in the upper and lower lid with puckering at the incision site. On elevation of the swollen lid, we could see the superficial vascularization in the inferior half of the cornea in the right eye, while pupil was round, regular, and reactive in the right eye. So this is the clinical picture photograph of the lady a few days after the surgery. So we can see the lower lid is well opposed to the eyeball. The margins are opposed, but it has changed in color, erythematous, and this is the yellowish discharge-like color. There is puckering in the incision site, and from that incision site, the swelling has extended all over to the cheek, moving over to the upper eyelid, and causing the decrease in palpebral height. We could just see the eyelashes, and in the medial canthal area, there is a scar which has gone like excavation, and the induration has extended well beyond the incision site. While in the left eye, the adnexa is normal, but she is exotropic, probably due to adherent glaucoma since childhood. So with this, we made a provisional diagnosis of right orbital cellulitis, And we started immediately the workup. We sent her for blood investigation, including serology. We sent the conjunctival and incisional swab for microbiology and culture. We also sent her for consultation with our ENT colleague for ENT evaluation. And we also sent for CT scan head and orbit to rule out any abscess foci. So simultaneously, we started the management, and we started admitted her and started her on empirical therapy covering gram-positive, gram-negative, and anaerobic organisms. So the blood investigations report came, and there was no leukocytosis. The hemoglobin, sodium, potassium, blood glucose, serum creatinine, all were within normal limit, and the serology was negative. So there was no organism isolated in the conjunctival swab specimen. ENT consultation said there is no abnormality, and in the CT scan, no abscess foci was seen. So 1 week post-op and few days after the IV antibiotics, we could see that she was responding well with the antibiotics because the lid edema was decreasing. But now, because the edema was decreasing, we could see the lower lid margins more clearly, and the lower lid edema has been more. It has subsided, but we could see the yellowish black tissue out here, and there is a scar more so in the tear trough region, and she complained of decreased sensation on and around the lesion. So this was on the she presented in our hospital. What this was in 1 week after IV antibiotics. We can see a depigmented line which demarcates the necrotic tissue with the normal healing tissue. So we revised our provisional diagnosis to necrotizing fasciitis. Since necrotizing fasciitis is not so common in our practice, so we thought of having a second opinion with a plastic surgeon. So we consulted him, and they diagnosed and reconfirmed our diagnosis, and they did a full thickness debridement of the necrotic tissue until bleeding healthy margins were met. They did a tissue culture and sensitivity of the tissue, and they found coagulase negative staphylococcus, which was sensitive to amoxicillin, cephalexin, ciprofloxacin, erythromycin, gentamicin, and levofloxacin. So now the final diagnosis was monomicrobial type 2 periorbital necrotizing fasciitis. Post-debridement and post-antibiotic of necrotic tissue, the patient was fairly comfortable. There was no erythema, no swelling, but she developed anterior symplepharon with the cornea, with the stump. And she had difficulty in eye movement, and it was also obscuring our visual axis and thus decreasing the vision. So this is in the close view. So we wanted to regain her motility, so we did a symplepharonectomy. For that, we also needed a large conjunctival graft. So we took an autologous graft from another eye, a big one. Then we did symplepharonectomy. Then we put the autologous cons graft here. So on the last follow-up, she had no pain, no necrotic tissue, good eye motility, though cosmetic disfigurement is still there. She had 18-part vision with central opacity with cataract in the right eye, and she is due for reconstructive surgery for the lower lid. So this was a timeline. Yes, she did lid plication surgery in another hospital. She came up after 4 days in our hospital, presented. We released the suture. We sent blood investigation, CT scan. Then we did IV antibiotics. Then here, after 1 month, she could undergo debridement of necrotic tissue. And after a few months, we could do symplepharonectomy with autologous conjunctival graft.
1 minute remaining.
So in conclusion, periocular necrotizing fasciitis may occur after any eyelid surgeries, and reports are there of after blepharoplasty, after retrobulbar injection, or after laser blepharoplasty. So clinical appearance may mimic tribal wound infection until sign of necrosis appears, and early diagnosis and management are key to success. I request my esteemed panelists, I would like to know how could we have predicted this and prevented this. And literature says that periorbital necrotizing fasciitis have less mortality than elsewhere, and our patient has no such any systemic features. Are we lucky in this? And how could I have done better management? I would like to thank the organizing team, my mentors, especially I would like to acknowledge Professor Dr. Rohit Saiju and Oculoplasty team at TIO. Thank you very much.
Thank you, Dr. Home, for the interesting case presentation. Now I would like to invite Professor Dr. A.K. Grover, sir, for the expert comments and opinion.
Thank you. Thank you for an excellent case. This is a rare case, as we know, and it's rare to get a periorbital necrotizing fasciitis. It has been very well managed, and the result is good. Further reconstructive surgeries will rehabilitate her further, take care of her ectropion as well. So thanks for this presentation, which increases our awareness to being aware of this condition and being able to manage this condition competently. As Dr. Gurang pointed out, we have these two types. The polymicrobial one occurs in immunocompromised individuals where aerobic and non-aerobic organisms are both involved. And the type 2 classically is one with either streptococci or staphylococci or a combination of these. Well, the diagnosis is important. It is important to diagnose the condition at an early stage, which we will see why it is important. It needs to be differentiated from just a simple cellulitis, either orbital or periorbital, as was the case here as well. But sometimes non-specific orbital inflammations or those with polyangiitis, such as vaginas, may also present with an inflammation like this. Sometimes rapidly growing malignancies also present a differential. The differentiation from cellulitis is helped by clinical features and by laboratory tests. If you have pain that is out of proportion and there are local features which suggest necrosis, it is important. Imaging sometimes is important because CT is the modality of choice, and sometimes it may show a subcutaneous fluid and air. And if that starts appearing, it becomes very clear, but the absence of that does not preclude the presence of fasciitis. If systemic toxic features are out of proportion, again, it is suggestive that we may be moving towards necrotizing fasciitis. There is a laboratory risk indicator for diagnosing of necrotizing fasciitis, which has been described, which includes these parameters, which are given a score. And if the score exceeds a certain number, you can think of necrotizing fasciitis versus an orbital or a periorbital cellulitis. That includes the TLC, the CRP, hemoglobin, serum sodium, serum creatinine, and blood glucose. So the scores assigned to these can be seen and added up. So antibiotic cover in necrotizing fasciitis may have difficulties because of limited penetration. And the preferred choice is the beta-lactam antibiotics, such as cephalosporins, as was used here. The third generation one was used, and penicillins. But a combination with clindamycin is considered as additive and provides the complete spectrum. And this is considered as the choice. And in type 1, the anaerobic should be covered with metronidazole, as was done here as well. Debridement is considered very important because it decreases the mortality almost 9 times if surgery can be done within the first 12 hours of diagnosis. But it is possible in these cases to spare a lot of skin and a lot of orbicularis because it's generally the subcutaneous or the fascial tissue which is involved, which can be extensively excised. So this remains the essential component of management, and the management was very adequate. Whenever the diagnosis was suspected, debridement was carried out in this case, as it should have been, of course. And thanks for this presentation. I'll invite one more input from any other panelists about what they think could or should have been done.
Just one question. Was there any histopathology as well? I may have missed it.
Dr. Gurang?
Yeah, so this debridement was done at a different institute by plastic surgeon, we couldn't get the histopathology report. Yes, it would have been very beneficial to get the histopathology report showing the necrosis and all, but unfortunately we couldn't receive.
Oh, no problem. I think you managed it very well. Was just one. I mean, I will request a comment from Dr. Grover about. We have at times this mucormycosis. Not exactly like that, but it can sometimes mimic this fasciitis. Number one. Number two is do we know what are the factors which will determine that this certain patient will have fasciitis and other patients will have cellulitis? Because both can occur in immunocompetent as well. So I will request Dr. Grover to please help in this question.
Thank you, Dr. Afghani. Those are very pertinent questions. I think only the severer cases will go into a necrotizing fasciitis, and we do not know exactly what factors contribute to that. More virulent organism, somehow lower resistance, even in the absence of an immunocompromise, can be the factors which will lead to this. We know of only two major causes, generally following trauma or following surgery. Whenever there has been a penetration, those are the two situations where a necrotizing fasciitis develops. And sometimes it has become virulent enough to cause, whenever a thrombotic change takes place, whenever there is a thrombotic invasion of vessels causing the circulation to cease, that causes a lot of necrosis. And that's the reason for fasciitis to become necrotizing. And it is similar in mechanism to what happens in our mucormycosis, where again, the vascular occlusion is the very, very important feature, again, because of invasion of the vessels by the mucor organism. In mucormycosis, we see a lot of cases, and an HR like this, a vascular supply-less area, both in the nose and in the periorbital region, with a blackish discoloration, with a central retinal artery occlusion developing, are the classical features of mucormycosis. It is very rapidly progressing at times, goes on to involve the other eye as well. So it is very vital to act immediately in cases of mucormycosis. We being in a general hospital where there are a lot of post-transplant patients, a lot of immunocompromised patients because of therapy, and most importantly, diabetic patients. So uncontrolled diabetes seems to be the most important triggering factor in mucormycosis. And that is the reason for immunocompromise in almost all the cases which we see with mucormycosis. Here, in this case, there was no immunocompromise, but then the hygiene conditions and the nutritional conditions of the patients may have played a role in relatively lowered resistance and presentation as necrotizing fasciitis.
Thank you very much.
Can we switch to the next one, please? Next presentations. Maybe the guest.
Thank you, Grover, sir, for enlightening us about this condition, and Tayyab Afghani, sir, for the great discussion. With this, the first session has come to an end, that is case presentation session. Now, I would like to ask Dr. Basant Raj Sharma, sir, who is President of Nepalese Society of Oculoplasty Surgeons, NESOS, to introduce our guest orator, Dr. Naresh Joshi. Dr. Basant, sir, please.
Once again, welcome everybody. And today it gives me immense pleasure to invite Dr. Naresh Joshi to give his talk on periorbital reconstructions. Dr. Naresh Joshi needs no introduction, and he has specifically directed me that he should just refer to him as a Nepalese who's working as an oculoplastic surgeon in the United Kingdom. Nevertheless, I would just like to say that Dr. Naresh Joshi is a great friend of NESOS and Nepal, and also he's in true sense, he has done a lot of work outside of Nepal, and he spends a lot of time giving lectures. As you have seen, we have been following his lectures, and we are learning from him every weekend we see his face on this thing, Zoom. So without much ado, I would like to request Dr. Naresh Joshi to take the stage and give his presentation. Thank you.
Dr. Basant, with your permission, I'll just add one word. Yes. Naresh is a doyen amongst all the oculoplastic surgeons around the globe, and especially in the field of aesthetics. His work is appreciated the world over as pioneering. So it is, and most important of all, he is a great friend to all of us in the South Asian region. And that's the reason I would say that we are very fortunate to have this inaugural symposium of OPSSA with orator of the caliber of Dr. Naresh Joshi. Welcome, Dr. Naresh Joshi.
I hope you can hear me. Please stop sharing.
Right. I think someone is still sharing a screen. I can't share my screen because somebody else is sharing a screen, it says.
IT team, please.
Is someone else sharing a screen?
I think you can start your screen sharing. I don't think there's anybody else sharing the screen, Naresh.
Okay, let me see. Okay, good. Thank you. Okay, can you see me now?
Yes, we can.
Okay. And see my screen?
Both.
Okay,
great. And your voice.
Okay, so I'm going to keep this very simple. I apologize. It's a long lecture that I'm going to abbreviate. My life at this point towards the end of my career is about simplifying things. And I try to simplify my life, and I try to simplify really to make things easy, not just for the patient, but also for me. So this is what I call periocular reconstruction, the 10 tips. And we know that this is a difficult area. It's difficult because it has complex curves, there's different skin types, and it's mobile. And we know one other thing, that the integrity of the eye is dependent on functioning eyelids. So here are some simple tips, and I'm going to go through them one at a time. The first thing to consider always in life is my intervention going to be better than leaving things alone? Now, this is a perfect healing environment. Consider delaying your reconstruction if you need time to think. And these are the two areas that are particularly well in spontaneous healing, the lower eyelid and the medial canthus. So I say this to all the trainees. Before you embark on any lower eyelid reconstruction, sit back and think to yourself. What I say is, in the presence of a functioning upper eyelid with normal corneal sensation and a good Bell's protective phenomena, you do not need to reconstruct a lower eyelid, whether it be a small anterior lamellar defect, a small central full thickness defect, a larger full thickness defect, or even larger defects than that. Let me show you a case. Here is a patient who has traveled from abroad seeking my help for reconstruction. She has an infiltrative lower lid basal cell carcinoma. This is her defect after Mohs micrographic tumor removal by the dermatologist. Not something we anticipated. So what should I do in this situation? She is in the country for a short period of time, having flown over to have this repaired by myself. She has had multiple aesthetic surgeries done around her eyelids and her face, not by me. I go back to what I started out by saying. In the presence of a normal upper eyelid, normal corneal sensation, and good Bell's protective phenomena, what would happen if she went back to her country? This is her post 2 weeks resection with no reconstruction. A normal eye, good seeing eye without compromising her vision. So you'll see there is quite a good spontaneous healing response. Sorry, somehow my face has come up. I don't, is my face come up?
Can you share the again content presentation?
Can you see it?
Yes.
Yes.
So this is 2 weeks post-resection, spontaneous healing. Now it's stuck for some reason. Okay, this is 6 weeks post-resection. You will see there has been a gradual healing process without intervention. And this is just over 2 months post-reconstruction. Admittedly, there is a slight lower lid retraction, but she has a comfortable eye with no intervention by myself. So if you have defects of this nature, what would happen if you waited rather than plunging in straight away to reconstruct this area? This is 10 days post-surgery. You will see that the defect is considerably smaller and perhaps easier to reconstruct. The other area that you may consider leaving behind is the medial canthus. And in my experience, almost any depth and to a degree almost any size, if it's isolated to the medial canthus, will heal spontaneously. And this applies to the forehead as well, which I'll show you later. If, however, the defect extends into the lower eyelid area and you're worried about the effects of the spontaneous healing in the lower eyelid, one of the things that you can undertake is a tailored purse string suture using a monofilament suture. So here I usually use a fiber PDS, and the benefit of this is that you can tailor it in such a way not to cause too much traction of the lower eyelid, and so you can greatly decrease the size, which means that the wound will heal much quicker. So, point number 1, consider whether you should leave things be, because you may have trained as a surgeon for 10, 20, 30 years, but the body has been in training for 8 million years, and I can assure you that it is better a surgeon than we will ever be. Next, direct closure. Whenever I see a defect, I think, can I close it directly? Now, there are many techniques to do this, and I'm sure that many of you have your preferred technique. This is the traditional technique of using sutures for both the tarsus, for both the horizontal and the vertical realignment. So I usually use a 5/0 or 6/0 double-ended vicral suture for the deep structures, and I usually use a monofilament, usually a Proline for the gray line and lash line. The only tip that I would give you is that it's worth considering leaving a little pout with a mattress suture, because the most difficult thing to correct after repairing is a notch. So if you leave a little pout, when you take the stitch away, you'll have a flattened eyelid as opposed to a notched eyelid, as you can see in this defect. One other tip, especially if you're closing the upper eyelid defect, is to consider a supraciliary incision which extends medially and laterally. Then when you repair the posterior lamella defect, you will not have an anterior lamella repair which is vertical, because whereas in the lower eyelid it is relatively acceptable to have a vertical scar, in the upper eyelid it is more obvious. Sometimes you will need to do a cantholysis. It is possible to leave a lower eyelid with an area of defect. Now here's a patient, very elderly, one-eyed, where you might consider, say, a Hughes flap, where I've chosen simply to detach the lateral area of the lower eyelid and mobilize it medially. Quite an unaesthetic appearance immediately after the surgery. But here's the patient roughly 6 to 8 weeks later, you will see that he has an acceptable lower eyelid in his only seeing eye. I have not had to cover his eye, and you will see an acceptable lower pseudolid in the lateral portion. The next thing is to consider whether you need to not just release the canthus, but also to mobilize the cheek area. I have to say, I don't follow the principles of 25% requires this or 50% requires this. It really is very an individualized process. If they have a great deal of laxity, if they have a one eye, I will always try to mobilize the tissue and simply stitch it together. If, however, you're going to use this technique or any other lateral migration technique, you will find that some of your patients will have an inferior migration of the lateral lower eyelid. So in order to prevent that, whatever technique you use, it is worth these 2 points. When you make your lateral incision, ensure that your slope is at least 45 degrees from a line drawn between the medial and lateral canthus. That will mean that as it scars and tightens, the pull will be superior as opposed to inferior. The other thing is to always fixate both the lateral canthus and the orbicularis skin flap onto the periosteum high up. If you do those 2 things, then you will reduce your risk of inferior migration of the lateral eyelid in your reconstruction. What about the Hughes flap? The Hughes flap I have not used for almost 15 years. I think it's an overused flap. It's a flap that we as oculoplastic surgeons use more than any other specialty because we're familiar with the tissues of the upper and lower eyelid. And it is an acceptable reconstruction. But I would say to you that if I had this patient now rather than many years ago, I would simply leave it to heal spontaneously. And I think the result will be as good as the Hughes flap you see here, which is acceptable, but always results in some malformation and malposition in almost all cases of the upper lid. Remember, the lower lid is expendable, the upper lid is sacrosanct. And if you damage the upper lid in any way, you will cause problems to the eyes. So consider direct closure whenever you can. The next tip is the concept of thick and thin skin of the periorbita. If you look at the skin, there is a transition from the thin skin of the upper eyelid to the thicker skin of the medial canthus and paranasal area. Repair like for like. So here is a case in whom you could choose many options. If, however, you're going to line it with flaps, then you need to think of the different thick and thin skin area. Now, you could line this whole area with a graft, but just for the sake of the principle, I want to show you what can be done. So I have mobilized the thin skin for the thin skin area, and I've mobilized the thick skin for the thick skin area. Now, that is a simple defect. What if you have a more complex defect, as in this case? Using the same principle and the principle of lamellae, I'm mobilizing a tarsoconjunctival flap medially from the same eyelid, attaching it to the medial periosteum. That is reconstructed the posterior lamella of the upper eyelid. Remember, the upper eyelid is the most important structure for the integrity of the eye. Then I have placed a skin graft to the upper eyelid because that is the skin that it normally has. You should not reconstruct the upper eyelid with a forehead flap. You will have an immobile and stiff upper eyelid. Now, sometimes that's necessary when you have no other options, as in Burns patients, but if you can, use a skin graft and a sliding tarsoconjunctival flap. So, and the thick skin with a central forehead flap. So, thin skin allows mobility, thick skin for stability. So here's a patient following reconstruction. and has an adequate reconstruction. But the most important thing is not what he looks like, but can he close his eyes? So it's not bad considering he lost most of his upper eyelid and a large area around that, the medial canthus and the forehead. So think thick for thick, thin for thin. The next is to consider cosmetic units. This is something that plastic surgeons do much more than us, and this is something I've learned from them. So if you're reconstructing an area, think of cosmetic units. Anything above this black line is an eyelid. Anything below is the thick skin of the immobile cheek. So I'm going to reconstruct the upper unit with upper to lower skin muscle bridge from the upper lid, and the lower thick cheek area with a temple rhomboid. And you can think about this when you're doing other reconstructions. Now I'm going to skip through this. Actually, I will skip through this because I don't think we have enough time. So think about cosmetic units in your tailoring reconstruction. Skin grafts. I think this is one of the most important tools that we have, and especially if you're starting out, rather than doing very complex flaps, a skin graft is an excellent tool to get you out of problems. This is especially useful for our burns patients. What can I tell you? Well, if you're going to place skin in the upper eyelid, you can use the graft as your skin crease. So I'm going to flick through this rather quickly. Can I just say that someone has their microphone and I can hear them? I'm not sure you can hear them, but I can hear them. So if you could please switch off your microphone, I'd be grateful. So this is set at 10 millimeters, and then you need to free all the subdermal scarring, and you will see a large defect to suddenly appear. You measure that defect. The key to grafting in the periorbiter is to thin the skin. I have never seen too thin an awful lot of too thick a graft. So here's the graft in position, and I usually use 7-vital repeat sutures as a continuous suture. And in this case, I'm removing some of the excess. Someone has the microphone on. If they could switch it, I'd be grateful. So the excess is removed and used at other sites. I usually then will put some glue to bind it down. And one of the things that is useful in the upper eyelid, where we cannot put a bolster on, and we want the eyelid to remain open if possible, is to use compression sutures. And I usually use a 5-vital suture that goes through the skin all the way down almost to the conjunctiva, and always use a protection. I use a contact lens, but also a forceps just to hold it down to make sure your needle doesn't go all the way through the conjunctiva. And if you use these compression sutures, you will bind the graft down even in the presence of mobility. So it's worth skin grafting patients much larger than you think that allows for eyelid closure. The tip on skin grafts, thin as possible, consider compression sutures in the upper eyelid. And the next, posterior lamella. I usually use buccal mucosa, almost always from the cheek, very rarely from the lip, although it's easier to access, it's very difficult to get a large enough piece. So if you're going to do it from this area, just to be sure you know where the parotid duct opening is. I will always suture, never leave it, because it takes a long time to heal with secondary intention healing, and it's not easy for the patient. You can always suture this, no matter how big the defect. And if you can, put the suture below the line of the bite. I have not used a hard palate graft in over 15 years. I know there are some who do, and I think I can get away with buccal mucosa just as well. So that's the reason I do not use it. But again, with buccal mucosal grafts, the key is this is a lining, not a stent, and therefore I will thin it as much as possible to be almost translucent. Here's a translucent posterior lining. So I use buccal mucosal grafts, usually from the cheek. I thin it as much as possible. The next, I'll move on to periosteal flaps. Please give me a 5-minute warning when I'm coming to the end. Periosteal flaps are extremely useful. They support the lateral eyelid. If you're going to use a periosteal flap, you can never make it too large. The key is to take as large a periosteal flap as possible, also to take it from a slightly superior position. You do not want the eyelid to be dragged down. So as long as it's large and it's superiorly based, it acts as an extremely good stent, as long as possible and as wide as possible. Here I'm splitting the periosteal flap into two portions for the upper and lower. And this is the analogy I use for the fellows. The upper has to be long and can be thin. The lower has to be wide and taut for support. And then you can stitch it on, and it's a very effective tool. So periosteal flaps, think of an asymmetrical design, use as long and wide as possible, and also superiorly based. Next, a forehead flap. This is something I've learned from my plastic surgical colleagues. Extremely useful flap in this area, and used for all sorts of periocular reconstruction. Why? We have such good perfusion in this area. Now, the most common flap that you'll use is a contralateral supratrochlear forehead flap. You can use a random flap that has no vascularity, especially if it's short in its length. The other tip in this area is if you draw a line between the median and lateral canthus, anything above you can slide, anything below you'll need to use a pedicle. So glabellar flaps do very well above this line, but if your defect goes well below this line, glabellar flaps are not as useful. And consider a pedicle flap. And here's a flap in a patient. Now I'm showing you this because it has a great aesthetic result, but I did what I told you should not do, which is to reconstruct the upper eyelid unit with a single flap. And that is the reason why this patient is ptotic, because this flap from the forehead has pulled the eyelid taut. I would need to remove this flap and place a skin graft for more mobility. If you have a large flap, if you're going to divide it, how do you know that you've perfused the area? Well, the technique that we usually use in the clinic is I usually use a disposable rubber glove, and I will strangulate the base in the clinic, and if this area remains perfused, then you can divide. If it blanches, then you will need to leave it for another week or so. So you will see here in a post-radiotherapy case where I've used an extra thick flap at the time of division because it's a perfused vascularized pedicle flap, an arterial spurt. So we often use a Doppler in the unit. It isn't always necessary, but the advantage of a Doppler is that you can use a high ratio flap. This is a 1 centimeter width flap, but a 10 centimeter long flap. Usually the rule is 1 to 5, 1 to 4. But if you use a Doppler, you can actually Doppler the vessel all the way up, and therefore this flap can be narrow, which allows for better rotation. So here's the patient who has a lower eyelid deficit and volume deficit, in whom I placed that long flap, which gives me volume as well as height. Now, one of the things about forehead flaps, which I've learned again from my plastics colleagues, is that it can be left to granulate. So you see this flap has been left, that large defect here has been left to granulate, and it granulates over a period of time. Just like the medial canthus, it does not require repair. Sometimes if you get a granuloma and it's much, much smaller, you can simply resect the granuloma 6, 8, 10 weeks later and do direct repair. So I'm going to quickly take you through a forehead flap and what I do. So here's the defect. You can mark up the defect, and you can place exactly the shape that you want. The next thing to do is to use a gauze to ensure that you have mobility and also length to place the forehead flap into position. Try to use a central forehead flap. If you deviate your flap above the brow, especially if it's close to the brow, you will change the brow position. Here I'm using a blade. I will lift the flap And the principle of flap lifting is in thirds. The distal can be subdermal, then you need to be submuscular, but the last bit where your vessels perforate from should be subperiosteal. As long as you stick to the principle of thirds, you will have a well-vascularized mobile flap. And here I'm lifting it up and I'm checking to make sure that it will fit, and it fits exactly because we had templated it before. The next thing to do is to realign your donor site. And I've drawn the lines for the furrows of the forehead to ensure that I have an aesthetic outcome which will not distort the forehead and the eyebrow. So once that's done, at least in part, you could leave the top section here to granulate, but it was not necessary in this patient. Now, here I realign the forehead, and then I'll come back. Now, you can then titrate the amount of thickness that is required. And as we know, different areas have different thicknesses. So I will try to moderate the amount of thickness that I have according to the area. The area near the nose will be left thicker. The area near the eye will be thinner. So you can, and I usually use a deep suture onto the periosteum to hold the flap into the concavity. And here's the flap in situ. So when you're thinking of forehead flaps, think, do you want a random flap, which is avascular, or do you want a Doppler, or at least one that is in the supratrochlear or supraorbital region? And think about the canthal line. Anything above, you can slide. Anything below, you'll need to use a pedicle. Second last, fixation. Fixation is extremely difficult in the medial area. Fixation lateral is relatively simple. So just a little point on fixation. The difficulty we have in medial fixation is twofold. Firstly, we have the lacrimal apparatus in the way, and secondly, we have extremely thin bone in this area. So, just a point about medial canthal fixation. We need to be as posterior and preferably slightly superior as possible, but the bone may be very thin. So there are two things that we use. If we have thick, strong bone, we will fixate that directly. Now you can use a little screw. We usually use what's called a Mitec, which is a pre-drilled hole that we insert this Mitec, and the Mitec screw fits exactly into the hole that you've drilled. And the advantage is that it has different caliber sutures attached to the screw, from 6/0, I think, to about 2/0 epibond, double-ended with two needles attached to the screw. Then it allows us to fix the eyelid apparatus onto the bone directly. So if you lack thick bone, then the only alternative is to use a plate which is drilled into the thick bone anteriorly and rotated posteriorly for fixation. So fixation techniques, I'm not going to talk about lateral fixation because it's relatively simple, but medial fixation, it really depends on if you have bone or not. And lastly, to finish off with, we have a number of patients who are sent to us who've had radiotherapy for their cancers, and they come back with recurrences, and we need to have a technique of treating these patients. In these patients, we need to use vascularized tissue, preferably flaps. The larger, the better. So here's the post-radiotherapy recurrence of a diffuse basal cell carcinoma. So in this situation, skin grafts should not be considered. So she has multiple flaps, both for the anterior lamella, a paranasal, and a cheek flap, and for the posterior lamella, a Hughes type flap. So this is a rare situation in which an periosteal flap, we will consider using an upper to lower lid flap for the posterior lamella, because a graft may not survive. Now, this is a technique which is very useful for those of you who exenterate, especially in the post-radiotherapy eye. This is a technique that really is something that I was taught by the craniofacial surgeons, and this allows the post-radiotherapy socket to be vascularized. So a hole in the lateral wall, and the anterior 2/3 of the temporalis muscle is mobilized and inserted into the orbital socket. Now remember that skin grafts will not take on this because of the radiotherapy. So a temporalis muscle is being used, and you can actually wrap a ball in this. This is very much Paul Tessier's technique of wrapping a ball in temporalis for this area. Then you have a well-vascularized zone that you can put a skin graft on. So in the post-radiotherapy eyes or sockets, where there is hyperperfusion, this is best managed with vascular flaps. I showed you the use of the 2/5 of the temporalis, but of course you could use a vascularized supratrochlear, supraorbital flap from the contralateral side if this area has not been treated with radiotherapy. So I hope I leave you with a few tips. Of course, there are many, many different ways of reconstruction. This is simply one person's analysis, and if you have a good technique, then you should stick to that. So I hope I've shown you some useful tips, but the biggest tip that I have learned is to work as a team, to work with others, to work both in oculoplastics and also, in my case, with a big craniofacial service. And this has been the real highlight in my life, is to work as a team in person, but now in a virtual sense. I hope that someday we will see each other again in person, but thank you for allowing me to speak to you on eyelid reconstruction. And this is my home team, and I look forward to welcoming you when you come to Nepal, Nepal, as well as the UK soon.
You can invite to Nepal as well.
Of course. Namaste, and thank you very much.
Thank you for that excellent education, Naresh. That was very, very useful. Hand over to the organizers.
Thank you, Dr. Joshi. It was a nice, excellent learning, and your presence has made our program more valuable. Now we are going to start our symposium today, that is Through Generations in Oculoplasty, Eyelid Trauma and Innovation. For a gentle reminder, I would like to say that the time for the speaker is 8 minutes, and we'll say it when 1 minute is left and 4 minutes for panelist discussion. So moving ahead, our first speaker of this session is Dr. Diva Hamal Lamichhani for her topic, Canalicular Trauma Tips and Tricks. Dr. Diva Hamal is an oculoplasty and oculoaesthetic surgeon at Viratnagar Eye Hospital. And she has done her fellowship from Telangana Institute of Ophthalmology and Tirupati Eye Hospital, Delhi. And she's also head of Department of Quality at Viratnagar Eye Hospital. Over to you, Dr. Diva.
Thank you, Dr. Prerna. Am I audible?
Yes.
Am I audible?
Yes, you are. Please go ahead.
Good evening, respected organizing chair, organizing secretary, panelists, guest speakers, and everyone here. Thank you for having me here today. At the outset, I'd like to thank the Nepalese Society of Oculoplasty Surgeons, Oculoplasty Society of South Asia, and Telangana Institute of Ophthalmology for this warm opportunity. And with this, I would like to start my presentation. I'm presenting about the canalicular laceration tips and tricks. As we all know, canalicular laceration constitutes about 16% of all the eyelid laceration, and 20% of the canalicular laceration is associated with global injury. It's more common in children and young adults and frequently affects the lower eyelid. It may be associated with other periocular or orbital injuries and may affect other parts of the body, so has to be taken simultaneously. It may be classified, canalicular laceration may be classified as direct injury due to penetrating trauma by sharp objects like glass, nail, or may be avulsive due to tractional force embedded on the eyelid, causing avulsion. Avulsive injury has been considered as the one of the most commonest cause of canalicular laceration. Talking about timing of injury, As we know, 6 hours is the golden hours, but 24 hours has been recorded as the standard timing for repair, with anatomical success about 96% and functional success about 92%. Various reports show different timings of repair as because the patient may be in ventilator or maybe in intensive care unit. Depending on that, it has been reported up to 360 months delay in repair with almost outcome of 96% of anatomical success and functional success of 88%. So all canalicular laceration must always be repaired, and rate of anatomical success and functional success are not significantly affected from the injury to repair. Coming to the management, it depends upon the surgeon to surgeon and the expertise. It may be managed under the general anesthesia or local anesthesia. So identification. Excuse me.
Sorry for the technical glitch. Or other than people are not able to see the slides, so I request to replay the slides. Thank you.
Okay. Is it okay? Is it visible? Am I visible?
Yes, you are visible.
Yes.
And,
for us.
But in the webinar Zoom link,
Okay.
it is not visible. So IT team, I request them to take over, please. It is not visible in the webinar Zoom link.
I can see it very well.
Okay.
It is visible to us.
So how can we proceed this? Can I continue?
Diva, you can stop sharing and again reshare it so that it
Okay,
will.
sir. Okay, sir. Thank you, sir.
So now it's visible.
So it's visible? Is it visible?
Yes,
It's
it is to
clear
us.
now.
Okay.
Now the participants are saying it's visible.
Okay, thank you so much. Okay, it can be repaired on the general anesthesia or local anesthesia, and the identification of both cut end of the canalicular are done, and the endocanalicular support is done by the stents, and the re-anastomosis of the cut ends are done. Then finally, the closure. All canalicular lacerations should be repaired on the operating microscope and a surgical loop. There is a lot of discussion about the suturing technique. Some surgeons prefer pericanalicular repair of the canaliculi, or some surgeons prefer direct canalicular repair. We prefer pericanalicular repair as we are only suturing the pericanalicular orbicularis oculi or the Horner's muscle and the other tissues and the middle canthal tendon if it is lacerated. In case of direct canalicular repair, the lumen of the canalicula are directly anastomosis with each other, but it has its own drawbacks about the cheese wiring of the canalicula can occur, and the strength is also not much. So pericanalicular is the suturing technique of choice at present, but still it depends upon surgeon to surgeon. Excuse me, there is some technical error going on. Dr. Prerna's photograph has been shown.
I think the IT people are trying to sort out. Your slides are not being shown to the other people, you know.
Other people.
Yeah. Other participants.
So I need to share again?
Yes, you need to share again, I think.
Am I visible?
You are visible to us. The problem is that the audience are not seeing it.
Oh, I don't know.
Not your problem. I think it's technical error.
Okay.
Not the problem from your side.
Okay. So coming to the suture material that I use, thick sutures are preferred always because thin sutures causes cheese wiring, and thick sutures gives you a good strength. Why? Some surgeons prefer to use Vicryl, some surgeons prefer to use polyglycolic acid, proline, or silk for the skin suturing. We prefer to use 4-0 Vicryl suture for the middle canthal tendon suturing, and pericanacular repair with 6-0 Vicryl suture, and the silk with the same. So identification and retrieval of the distal end of the canaliculus is sometimes so easy because of seeing the calameter ring sign, which is just everted epithelium that is seen around the bed of red orbicularis oculi. But sometimes it may not be visible. In such situations, we can take the help of air bubble in a flood of normal saline, or a viscoelastic substance, or an adrenaline can be used. Surgeons have also reported of use of pigtail probe, and also ice compression and hyaluronic acid at the time of repair reduces local tissue edema. A fiber optic light pipe model 23 has also been reported to be used in case of delayed laceration repair and in complicated laceration. And also chandeliered illumination guided of 23 gauge fiber optic probes have also been used with successful outcome in case of delayed laceration repair, which is advocated with bicanalicular stent. Now, monocanalicular stent are always a hero in case of canalicular laceration repair, as it gives around 90% of the anatomical success and functional success, about 100%. We use oro stent that is similar to mini monaca, and that is 40 millimeter in length, 0.64 millimeter in diameter, and it has a self-retaining valve that just fixes at the canthus and canaliculi, and the anatomical success around 98% is observed, and functional success about 83%. We will use this oro stent even in bicanalicular laceration and in monocanalicular laceration. These are outpatients. Crawford's bicanalicular stent has been also advocated in case of bicanalicular laceration repair with extensive avulsion of the middle canthal lesion, and also in case of delayed repair of laceration, Crawford's bicanalicular stent has been advocated. New silicon mastercut tube for monocanalicular repair has also been reported to be used, and it is similar to the other used as other monocanalicular tubes intubation system, but it has an additional advantage of having the introducer, and its length is only 35 millimeter. And they have reported a success, anatomical success about 87% and functional success about 100%. They have also discussed, surgeons also think about the economy. Sometimes the stents are not available. Sometimes the patients are not affording. In such situations, surgeons have come up with ideas of using 20G silicone rod oro stent with success up to 70%. And also 20G's angiocatheter tube has also been tried. We have also tried in our setup in one patient. So duration of removal of tube has also been always been a debate. So, report literature shows they have removed the stent after 6 weeks, 2 months, 3 months, or even delayed because of the patient not following up regularly in a advised time, and then the patient has been removed after 2 years, and still the anatomical success is 100%. So studies on normal healing suggest that process of proliferation and fibrosis is to be done within 3 months. So we have been removing our oro stent within 3 months in all our cases till now. So talking about monocanalicular stent and bicanalicular stent, monocanalicular stent always acts as a hero and with a very good outcome, and also ease of insertion and removal, and also it has a self-retaining cap that sits in the punctum, giving an excellent stability and avoids extrusion and displacement. On the other side, bicanalicular laceration also, bicanalicular stent also acts as a hero in case of bicanalicular laceration with extensive avulsion of the middle canthus. So in such situation, it provides an adequate posterior medial traction force on the eyelid and the canalicular system for the desired wound healing, and also it gives a good stability. But the cumbersome is that to withdraw the tube from the nasal cavity is another difficult situation. We can take the help of nasal endoscope for this, and also for the removal of the tube, we need to remove on operation room setup. So besides this, it is cost effective, easily available in the hospital wherever the dacrocystorhinostoma surgeries are done. But there are some complications like cheese wiring, punctal erosion, canalicular slitting, granuloma formation, superior loop dislocation, and infection and corneal aberration can be seen. Coming to the complications, as I've already said, others, the punctal granuloma can be there, punctal slit, lid margin notching, lag of thalamus, hypertrophic scar, infection, tear can always be there. It depends upon the surgical technique.
1 minute left, Dr. Diva.
And depends upon the expertise of the surgeon. So I'd like to conclude by saying good anatomical knowledge, meticulous approach, expertise of the surgeons are vital. Primary repair is the best repair as early as possible. Thick sutures gives good support and approximation, and stent removal should be done at least after a minimum of 3 months, and all canicular lacerations should be repaired. Thank you.
Thank you, Dr. Diva, for the nice presentation. Now, I'd like to invite our panelist, Dr. Basantara Sharma, sir, for the comments in this regard.
I think Diva needs to stop sharing her screen.
So I have already stopped sharing, sir.
Okay. Thank you, Dr. Diva, for the excellent presentation. You have made, sorry, let me just check my video. Okay. Okay. Okay.
Sir Boshan, you are not audible.
I'm not audible? Okay. Now it's fine. Okay, good.
Now better, yes, please.
Yeah, okay. So, thank you, Dr. Diva, for that excellent presentation. And you have made my my discussion much easier because you have covered most of the points there. And I would just like to start by showing you some of these pictures. This is what these are slides which are like 12 to 15 years old. So this is what we were doing before. And a lot of times we would just leave the tube hanging from the eye. This is a lower clavicular trauma, 60-year-old male with blunt injury. We have to realize that any form of injury, it doesn't have to be penetrating injury, but just a simple blunt injury, like this was a fist injury, which led to, because the tissues in the medial canthal area, especially along the canaliculi, are so delicate that they tend to get injured very quickly. So this is a patient who had who we did a pigtailing. That's what we called it in those days. So this was canaliculus that was pigtailed, and then we removed. And this is another boy who had undergone injury, and then this is 6 weeks post-operative. And we, again, these were the days when we didn't have stents, and we just used to pigtail them. And you know, the success rate was very variable, like 50% success rate, because as you know, we will discuss why I mean, though you may spend hours just tenting the canalicular system, eventually you do not address the deeper trauma. So, and many a times for such cases, this is a fan blade injury, and we would, in such cases, we just kind of repair the lids and leave the canaliculus for repair later on. Similarly, in this injury, orbital foreign body, where the whole sugarcane bit has gone inside the orbit, and this is the sugarcane, and this is extensive damage to the medial canthal area. Here also, in those days, we would never attempt to repair the canaliculus, but just repair the wound, remove the foreign body, and repair the wound. But then, how do we proceed now? The questions we have to need to be addressed are who, when, where, and what. For who? Now, as she has already mentioned, canalicular repair is a very delicate procedure. The surgeon, whoever is performing, needs to have some experience, or really needs to be experienced to do a proper job. Otherwise, what happens is you are doing more damage when you're trying to repair this canaliculus, trying to stent it, and you're doing more damage, and eventually you lead to more scarring than if you were to refer that patient to a higher center. But the situation in our country and in a lot of other countries in South Asia, and especially those who working in the periphery, know that this is not possible, because a lot of times the lid repair is done by simply a technician who will then be referred to you for further repair. But as far as possible, and this is where the responsibility and the role of bigger institutions that are running fellowship and residency programs is to educate young surgeons in the proper way of managing canalicular lacerations, and the proper techniques used, the proper devices that needs to be used, and where and when to do these repairs. So once you know who is going to repair. So for the who, the answer is that a surgeon who is experienced enough in doing canalicular repair should be doing canalicular repairs. Otherwise, it is very difficult. You are doing more damage, and the results are going to be very poor. Next.
Sir, we have less time now.
Okay. So when is the question? When is, as she has already mentioned, ideally the earlier the better. But then nowadays they say within 48 hours. So now they're saying that you can repair it up to around 2 weeks time. So that's when you can do. Whereas I think preferably you have to. It's better to do it in a OR setup where general anesthesia is available, so that you can actually assess the injury better. And also, there's less trauma using general anesthesia than when you're using local anesthesia. What are the devices? I think for now, a lot of people don't do pigtailing anymore, and they have changed to either monocanalicular stents or to this thing, bicanalicular stenting. Only thing is, fortunately, monocanalicular stents are now more freely available in our country also. So for surgeons who are not very experienced in bicanalicular stenting, I think monocanalicular stents, especially for lower lid lacerations, which are the most common laceration, monocanalicular stents are very effective. For the larger lacerations and for bicanalicular lacerations, I think the bicanalicular stenting is the way to go. But the thing is, a bicanalicular stent is a tricky procedure, and you really have to be experienced in probing properly the lacrimal system and then introducing these into the lacrimal system. Otherwise, once again, if you are causing false passage or other problems, you're doing more damage than good. And another thing is the quality of the stents, the proper tubes and all also comes into consideration, because a lot of times they'll just slip off. So I think in our situation, monocanalicular stents are a good option. And if you have the experience and if you have the availability of general anesthesia, then probably bicanalicular stents is the way to go for canalicular repair. Thank you.
Thank you, sir.
Thank you, sir. It was a nice discussion there. Now we have our faculty speaker, Dr. Shruti Tara, and her topic is hidden foreign body in eyelid trauma. Dr. Shruti Tara, she is a Chief Medical Officer and consultant in Orbit and Oculoplasty Department at Sankara Eye Hospital, Coimbatore. She did her post-graduation from Kasturba Medical College, India, and fellowship in comprehensive ophthalmology from Sankara Eye Hospital, and long-term fellowship in Orbit and Oculoplasty from National University Hospital, Singapore, and short-term fellowship from L.B. Prasad Eye Institute, Hyderabad. Dr. Shruti, screen is yours. Hello.
Hello, am I visible?
Yes, ma'am.
Thank you, Dr. Prerna, for the introduction, and I also thank the NEPLI Society of Oculoplasty Surgeons, Dr. Rohit Saiju and Dr. Ben for having me here. The next few minutes, we have seen various foreign bodies, heard various foreign bodies that have been injuring the eye in the eyelid trauma, and have removed quite a few of them. Not so obvious ones, but in the next few minutes, I'll just go through two case presentations, one with organic foreign body and one with an inorganic foreign body. The organic one, which is not so conspicuous, unlike the inorganic one. So this was a 35-year-old male who presented with redness, minimal lid edema, and a very vague pain.
Can you have your slide sharing, please, Shruti?
Am I not?
No, your slides are not visible. We can see you. Please start your slide share.
1 second.
Button down.
Hang on. Thought I did press share, but I'm not sure why it is not coming through.
Shruti, what you may need to do is start your PowerPoint.
Yeah, I'm doing that. I'm doing
slides, put it to one side, and then.
Yes, I'm doing that. Is it visible now?
Yeah, it is.
Is it visible as a? Yeah. Is it okay now?
Okay.
Yeah. So let's start from the very beginning. So these are some of the foreign bodies that we have encountered and removed some of them. In the next two presentations, as I told, one I would be discussing on the organic foreign body and one would be an inorganic foreign body. The organic one is a very small, inconspicuous one, and which kind of caused a diagnostic dilemma. So he was a 35-year-old male with a history of cold for 1 week duration. This was what was misleading, with no obvious history of trauma and not associated with any visual disturbance. So he came in with the visual acuity of 6.6 with full ocular movements, with mild edema and a conjunctival congestion. His pupils and fundus were normal. So we thought probably it is preseptal cellulitis, where it's a very vague term, but then yes, that is what we thought it could be, and was not sure what the cause. Probably we attributed it probably to the cold that he had. So we started him on amoxicillin and clavulanate, 625 milligrams BD, and diclofenac and serratiopeptidase. Well, 2 days later, he came back with no improvement, but this time he complained of pain on adduction, and he also had mild proptosis. Then we sought out for the investigation, and this was what was told by our radiologist. He said it's a vascular tumor with a big feeder vessel. So this was what it was. He said that's a feeder vessel, and I told probably this could be some foreign body. He said, well, no, it's a feeder vessel, it will bleed. So be careful when if you're trying to explore. So he put that fear of that doubt in me. And so what to do next? He came in a week later. He presented with a swelling of this kind, of 5 by 2 centimeter over the medial aspect of the right upper eyelid. Now this looked pretty much like a granuloma to me. So on probing, he gave a very vague and a trivial history of trek into the jungles, almost 2 weeks back. So I again went into our radiologist and asked him, can you repeat the imaging? And he said, essentially, there is no change in the report. It is still a vascular tumor. He said, probably it could be an air pocket, but this time there is an exophytic component projecting anteriorly and causing a mild proptotic effect. I said, okay. So this was what it was, and he said this is a vascular tumor and it is enhancing on contrast, and he said again it might bleed. So I thought, okay, no matter what, it looked like a granuloma. I said, okay, fine, let me just explore and see, or even take a biopsy if it turns out to be really bloody. And this history was something which kind of prompted me that probably there could be, a trek into the jungle was something that kept, that red flag which kept telling me that there could be something, there could be a foreign body. And what happened was we saw these wooden fragments. They're not really huge. They're the really small ones. They came out in 3 pieces. They were very friable. And post-operative period was uneventful. His minimal orbital cellulitis with that, little bit of adduction and little chemosis that he had and proptosis, everything settled down on day 2. So challenges are these. These are like small, fine foreign bodies. If it's a real huge wooden piece, you can actually see it as a radiolucent, black, opaque piece. But when they're very small, it is rather difficult. One is excision, because they can be multiple, they can be very friable, they can cheese wire, they can break, and a little difficult to remove all of them. If you are not vigilant and don't remove them, don't dissect them actually. So these are notorious for remaining quiescent initially. Initially, they might not have any reaction at all. And the wound of entry will invariably be very small, especially if they are splinters and if they have a very sharp edge. So it can be small and it can even be self-sealing. Like in this patient, it was self-sealing. So he really did not think that he had anything inside his orbit. And since it is porous and organic nature, it provides a good media for microbial agents to grow in them. So I did a little bit of research and then spoke to a radiologist, and what he said was, in the acute phase, CT scan is the choice because it shows air pockets within the wooden piece. The wooden piece will have a few porosities and the air pockets are seen within, and that can be captured in the CT scan in acute phase. Whereas if they pass even after 3 or 4 days, the air will get absorbed and it will have both, it will be hypointense almost relative to the intraorbital fat, and adjacent hemorrhage and fat can mix and confuse the density. So is there some way that wherein we can actually come to some kind of a conclusion, or which can take us somewhere to a lead, is by asking for this Hounsfield unit. So this Hounsfield unit for wood is about -204 to 36. If you ask for the radiologist, they would give something as the Hounsfield unit, and that kind of can help us say what probably the foreign body would be apart from the history and other things. And this was another patient. The history of road traffic accident almost 2 years back. The primary lid tear repair and primary enucleation was done elsewhere. He presented to us after 2 years with mild tenderness in the superomedial quadrant. So I advised imaging because he said it was a road traffic accident, but he refused. He asked for some painkillers. And he comes back to me after 1 month. This was how he was on presentation. And this was how he came with a little bit of edema there. And looking at the socket, this was what he had. This was again another granuloma. So what was similar in both these patients is this granuloma, or sometimes there can be a discharging sinus. These are the ones that we should kind of red flags, which can tell us that probably there is a hidden foreign body within. So we did an exploration after imaging this time, and it had a radio-opaque, well-circumscribed foreign body. It pierced the frontal sinus. It was very close to the frontal lobe, which gave again the Hounsfield unit of 2,400, which is
1 minute left, ma'am.
Sorry?
There's 1 minute left, ma'am.
Okay, a Hounsfield unit of 2,400, like a glass, and history of RTA, which shattered windscreen, was what he gave. And with the neurology standby, we took out, just in case he has a CSF leak, we explored and removed this glass piece. So this was how he was post removal. And he's due for lid reconstruction and prosthesis later on. So I did a little bit of literature search, and then what are the kind of foreign bodies that we really need to remove? Organic, yes. If it's inorganic, if it's anterior, if it's palpable, remove it. If it's not palpable, very small, if you can monitor it, monitor. If you have to remove it, if there is inflammation, infection, or if there is any functional defect, If it is epibulbar, consider removal. Again, if there is inflammation, infection, or functional deficit. Consider removal if it's posterior. Again, if there is an inflammation, infection, optic nerve, functional issues with the optic nerve. But again, if the epibulbar foreign body is like iron, copper, then you might have to think about exploring and removing it. So what are the take-home points? Good history, clinical features and the way they present, adequate radiological correlation, and in times of need, a multidisciplinary approach in exploration and removal. So this was when I was with Tilganga, Dr. Ben and Dr. Saiju. We had a wonderful time there. And this was an exhilarating experience on the mountain flight, and a very humbling experience looking at Himalayas at such a close quarters. Thank you so much.
Thank you, ma'am. It was a very nice presentation. Now I'd like to invite Dr. Ben Limbu for his expert comments on this.
Thank you, Dr. Prerna. It was a wonderful presentation by Dr. Shruti, whom I know for the last 2-3 years, and then since I knew her, I found her to be very good humor doctor, and she's excellent to what she is doing. So apart that, I found her drawing and passion into drawing was so nice. Art was so nice, and then her color passion is also so well that I'm kind of fan to her now. But anyway, regarding the presentation, I would like to add on the foreign body, specific vegetative foreign body are always masquerading. And as Dr. Shruti said, it can either present with granuloma or with the discharging sinus. Whenever we see this, we should always suspect a vegetative foreign body into the orbit. Apart from the eyelid foreign body, we should also, whenever we see a foreign body into the eyelid, we should suspect the extension into the orbit. I think that was an excellent presentation by Dr. Shruti. I don't have any other thing to comment. Well presented, Dr. Shruti. Congratulations.
Thank you, Dr. Ben. I think you were very kind with your compliments. Thank you so much.
Thank you, sir. Now I'd like to hand over the further session to my fellow moderator, Dr. Ashish Raspant.
Thank you, Dr. Prerna. For the next presentation, I would like to invite our faculty speaker, Dr. Samira Irfan, who is a consultant pediatric ophthalmologist, strabismologist, oculoplasty surgeon, and ocular surface disease specialist, who is joining us from Lahore, Pakistan. She is also the Vice President of Oculoplasty Society of South Asia from Pakistan. I request her to present on the topic mammalian gland disease, the underlying culprit in almost all ocular surface problems. The screen is yours, Dr. Samira.
Hi, good evening, everyone. Thanks very much for inviting me to this wonderful webinar, and I'm very grateful, Professor Basant Raj, Professor Grover, Professor Ghulam Haider, all the panelists, and especially the Nepal Ophthalmic Society. Thank you. So I'll be talking about meibomian gland dysfunction and share. Okay. Is it visible?
Yes.
Okay. So when we see the ocular surface infections, as clinicians, we need to ask ourselves two important
Start the slideshow so that we have a full screen. Yeah.
Okay. Full screen. Okay.
Yeah.
So when we see an infection in any patient of the ocular surface, we need to ask ourselves what is the source of the organisms and why did it occur in this particular patient. Normally, there are flora on the eyelid and the conjunctiva, but most important being staph epidermidis, and then streptococci, corynebacterium in small concentrations. They cause disease in patients, particularly who are diabetics, in advanced age, where the ocular surface immunity and the general immunity is reduced, poor hygiene, especially ladies who are using cosmetic makeup, then allergies, chemical irritants, acne, wearing contact lenses, which alters the ocular surface immunity and especially immunosuppression. So normally the bacteria, the flora, the normal flora, they don't cause disease as long as the tear film is healthy. So the concept of ocular surface was given to us by Toft in 1987, and this is an integrated functional unit comprising of 6 structures: the cornea with the precorneal tear film, the conjunctiva, lacrimal glands, and the meibomian glands, and they all work together to protect the exposed cornea and to maintain it as a smooth, shiny surface for a perfect vision. All these 6 structures, they share a common blood supply, nerve supply, and a hormonal control. And they have contiguous epithelia that merges with that of the nose and the paranasal sinuses. So the disease of one will not be restricted to that particular structure, but it will affect all the 6 structures. An infection can easily spread from the nose and paranasal sinuses to the ocular surface. So in any patient, we need to look into all of these. Meibomian glands, they were described for the first time by Heinrich Meibom in 1666, and they are an important constituent of the ocular surface. There are 30 to 40 glands in the upper tarsal plate and about 25 in the lower lid, and they are the modified sebaceous glands. And as you see the structure in this in the picture, they are compound racemose glands, each gland consisting of acini, which are circularly arranged along a central duct and connected by short ductules. Each acinus, it pours its secretion into tiny ductules and then into a common duct, and by the contraction of the rhyolin muscle, which is a part of the pretarsal muscle, with every blink, the meibum is squirted out onto the lid margin, and it serves important functions like providing a smooth, polished optical surface for the cornea at the air-lipid interface, and thereby reducing optical aberrations. It reduces evaporation of tear film and maintains it in between blinks. It stabilizes the tear film. Without meibum, the tear film will get reduced and dried up. Then during sleep, the meibum, it seals the opposing lid margins and prevents exposure keratopathy. Meibum prevents spillage of tears from the lid margin onto the skin and prevents its maceration. So as long as the tear film is healthy with its constituent immunoglobulins, lysozyme, and mucins, normal flora cannot attack the ocular surface. An infection only occurs when microbial load increases once the local ocular surface immunity is reduced. So the term anterior blepharitis, normally the blepharitis means inflammation of the lid. And because the eyelid is divided into 2 lamellae, the anterior and posterior, anterior blepharitis means anterior lamellar infection, which is eyelashes, the skin, and the underlying muscle. The anterior to the gray line is the anterior lamella. And usually it is due to the staph blepharitis. Staphylococcus aureus is, as I showed you the first slide, is only about 0.86% as a constituent part of the normal flora. But if its concentration increases, then it causes the blepharitis, in which there are formation of these scales which are stuck to the eyelashes, and if you remove these scales, there are underlying tiny ulcers. And it's a chronic load of bacteria that are supplied to the remaining ocular surface structures. And these staph can cause thickening of the eyelid margin and recurrent styes along with marginal keratitis or even corneal ulcer. So in all these patients which present with a corneal ulcer or a marginal keratitis, blepharitis is the first thing that needs to be looked into. Then squamous blepharitis is In this, there are production of these dandruffy scales, and this is because the glands of size, they secrete abnormal, excessive neutral lipids, which are split by Corynebacterium acne, which are again a part of the normal flora, and the squamous blepharitis is associated with dandruff of the scalp. And again, the load causes, it provides the bacteria and for affecting the remainder of the ocular surface. Then pediculosis, this should be looked into in children. Demodex infection, it can also cause these cylindrical scales which are formed surrounding the eyelash follicles. And then Demodex, there are two varieties, the follicularum and the brevis. Follicularum stays around the eyelash follicles and can cause recurrent styes, but the brevis, it penetrates deep into the meibomian gland ducts and can cause recurrent styes, granulomas, and very widespread infection. So anterior blepharitis is a constant source of bacterial load. It should be looked into in all ocular surface infections like recurrent conjunctivitis, meibomitis, dacryocystitis, marginal keratitis, then tear film instability, and corneal ulcers. The term posterior blepharitis was described to us by Bob and Heinrichs in 1980s. It is highly prevalent in Asians in about around the age of 40. It's seen in about 60% of people, general normal public. But as the age advances, then it is prevalent more and more, and it is a main supply of bacterial load. So it can occur due to obstructive duct by conjunctival scarring, which can be seen in chemical burns, ocular pemphigoid, Sjogren syndrome. Duct is commonly obstructed by desquamated epithelial cells, and that is because a part and parcel of aging process. When with advancing age, there is less of androgen supply to all these glands. So this the normal epithelium, it becomes keratinized, and this keratin, it blocks the main duct of the meibomian gland, and meibomian gland dysfunction starts. The secretion can be reduced in response to a lot of medications like anti-glaucoma therapy, antihistamines, antidepressants. So too much oil or too little oil, it breaks up the tear film. The bacterial lipases, they break up the meibum into free fatty acids, and these free fatty acids then react with protein in the tear film to form soap, which is manifested as froth on the, as seen in this slide, froth on the lid margin. And this froth is just lying there, soaked, constantly irritating the eye.
1 minute remaining.
Really? Oh dear. Okay. So the meibomian gland dysfunction is described as a viscous, waxy, white secretion upon expression with froth at the lid margin. And there is, because of blocked duct, there is loss of acini, metaplasia of the meibomian glands, and it can lead to distichiasis, as well as it can lead to sebaceous gland carcinoma. A simple meibomian gland obstruction with a clay can present with a clasion, but if the patient's general immune status is low, then it can lead to preseptal or orbital cellulitis, and it is a main cause or an important cause of non-healing corneal ulcers. And as I said, metaplasia can result in carcinomas. So every painful lesion, it presents as a painful lesion, the acute meibomian gland dysfunction or meibomitis. But if there is a painless infection, as in this case B, she had a painless swelling of the lid, and the ophthalmologist, he thought it's a clasion and sent her home with an antibiotic ointment. And then within 1 week, then the swelling, congestion increased, still painless. And in 10 days, it presented as this picture. But the whole in the whole time, patient has no generalized symptoms, and it's a painless process. So an urgent MRI was done, which showed 4 tumors inside the orbit, and it was actually a multiple myelomas. So a painful lesion, yes, it is infective, but a painless is a passive congestion, and that point has to be kept in mind. So to diagnose meibomian gland dysfunction, you have to see the pattern of staining of the cornea and conjunctiva, and you have to gently press onto the meibomian ducts and see the expressibility of meibum. Is it very easily expressed, and it is a clear colorless droplets on the eyelid margin, or it is thick and viscid and difficult to express? Meibomian gland dysfunction usually causes an inferior corneal and conjunctival staining, and you can grade it. Similarly, the tear film breakup time, it gives you an idea whether there is a tear film deficiency occurring. Meibomian glands can be viewed with the infrared camera or simple by an autorefractometer. You can evert the lid and can view it in a red-free filter. So diagnosing MGD, you have to look for risk factors, because it can, from a slightly red irritable eye, it can result in diffuse and severe blepharospasm, and patient loses all function and vision to this orbital cellulitis. We do not want patients to go from a simple red eye to the stage where the whole meibomian glands are keratinized and lost, because that is an untreatable stage. It was when the patient comes first, we need to grade it so that we can institute the therapy accordingly. So grade 1 is an asymptomatic patient, but still there the meibum is thick, viscid, and need pressure to express it. And grade 2, where there's cheesy meibum and there's frothing on the lid margin. Grade 3 presents with a severe dry eye. And grade 4 is there is total loss of meibomian glands with notching apparent on the lid margins. So principles of management is that we need, because it's a long-standing problem, we need patient education. We need to control the predisposing factors. We need to establish the flow of meibum by hot fomentation, massage, manual expression, lid scrubs, exercises. Since it's prevalent in even general public, we need to educate them, even the viewers and every one of us who are more than 40. We need to do these exercises to squeeze the meibum out of the glands early in the morning, because they get pent up during sleep. So squeezing them out increases the blood flow to the meibomian glands and melts the meibum. These exercises are extremely important for everyone. Then we have to restore the quality of meibum by anti-inflammatory therapy in the form of tetracycline, acetylcysteine, and anti-inflammatory agent like cyclosporine, tacrolimus. And we have to give lubricants to such patients and control the bacterial overgrowth. The international workshop, it just gave us these algorithm. I'm sure you can go through it. It's there on the internet. So massaging upwards the glands, lower lid upwards, upper lid downwards, and then melting the thick meibum with hot towels is important. So you have to put the hot towel on the eyelids and for 2 minutes, and then massage the melted meibum upwards. LipiFlow is intense light therapy, and it can do the same, but I think hot towels are easier. All this was published in as a book chapter, and you can read all that in this. So thank you very much. It's a common problem and needs to be looked into in every case of ocular surface infection. So thank you very much.
Thank you, Dr. Samira. That was an excellent presentation highlighting the importance of treating the innocuous looking meibomian gland disease. I would now like to request our professor, Dr. Rohit Saiju sir, to put in his comments on the presentation. Dr. Saiju, please.
Hi, Samira.
Hello.
Thank you for being with us, accepting our invitation. And you won in the bargaining of the time. It was given just 8 minutes, and you asked 15 minutes. If I asked 8 to blepharitis and meibomian gland dysfunction, and you took close to 15 minutes. So that's why I said you won the time. It's a great meibomian gland dysfunction is one of the underdiagnosed, undertreated, and most of the time it is asymptomatic and presented with symptoms of other ocular surface diseases. That's why it is ignored or it is poorly managed by most of the general ophthalmologists. And you highlighted very well. So everyone have to be very conscious about the meibomian gland dysfunction. We don't have the data of this type of entirety in our part of the world, but it is said is very common in the United States. 70% of the people over the age of 60 years are suffering from meibomian gland dysfunction. So that's great. It is very simple management, but we are ignoring to continue for a long time, as just the lead scrubbing and put the hot compression over the lead, which make the liquefaction of the meibum and making the more expressibility and secretion quality better with this hot compression over the affected portion. And then we have to continue for a long time, at least for 6 weeks, sometime for 6 months. So these are the things. If you don't look very carefully and find the things properly, you don't properly manage it. Like you miss the follicular conjunctivitis when you miss the molluscum contagiosum. You try many drugs. If you don't treat the molluscum contagiosum, follicular conjunctivitis will continue for months and years. In the same way, yeah. And looking at your one of the exercise you have explained, that is squeezing the eyelid at the night time or during the sleep, before the sleep. Maybe I'm thinking that in essential blepharospasm, people may not have the meibomian gland dysfunction because they are screeching the eyelid whole day and night. This is just my, the thought that essential blepharospasm people may not get.
And that is the end stage of missing the boat. We have missed the boat.
So that's why they don't have the typical presentation. It may come with the marginal keratitis or inferior conjunctivitis and severe dry eyes, because the meibum, which has a big role in the retard the evaporation of the tear film, will produce in their deficiency the evaporative type of dry eyes, and we just treat the dry eye without knowing the exact causes. That will be mislead the proper management. So that's great. Very nice presentation. We enjoy your talk, and we enjoy your presentation. And we always enjoy the way you are presenting with the smile. We memorize that. Thank you. Thank you very much, Samira.
Thank you so much. It's a pleasure.
Thank you, Samira, and thank you, Rohit. It was a wonderful presentation because it highlighted something that is very important. If I say that the commonest presentation in my OPD is a meibomian gland disease. Most of the patients who present with watering to us are meibomian gland disease patients who have relative dry eye, evaporative dry eye, and get a compensatory epiphora. So it is very important to diagnose them, treat them. Use of LipiView, which also gives us the structure, the extent of obstruction, extent of loss of glands, and also the lipid layer, partial blinks. That is very useful. And LipiFlow treatment that we do in some of them has also been helpful. So it is really good to diagnose them because you can treat them adequately. Of course, oral doxycyclines and fomentations all have a role. One very important oculoplastic connotation is that I found that a very large number of the idiopathic punctal obstructions that develop or the canalicular obstructions that develop are those who have a severe meibomian gland disease in our organization. And that's the reason for the continued inflammation of the surface and of the canaliculi and punctum, leading to their permanent obstruction. If they're picked up early at the stage when they're only covered with debris and you treat meibomian gland disease, you prevent many of them from going into a meibomian obstruction. This is something that has not been adequately spoken of in the literature, but we need to emphasize this.
Very true, sir.
Agreed, sir.
Thank you,
Thank you,
sir.
Professor Rohit Sainzu, sir, for the wonderful briefing and comments, and also Ekik Grover, sir, for added comments on the presentation. Our final presentation for the evening is going to be delivered by our faculty speaker, Dr. Murtuza Nuruddin, who is head of the Orbit and Oculoplasty Clinic at Chittagong Eye Infirmary and Training Complex at Chittagong, Bangladesh. He is also the organizing secretary of Bangladesh Oculoplasty Surgeon Society and international scholar of International Council of Ophthalmology. He will be delivering his expertise on periocular trauma. The screen is yours now, sir.
Thank you. I think there is someone else sharing the screen. Okay. Am I audible clearly? Am I audible?
Yes.
Yes, Murtaza.
Yes,
Yes,
sir.
please.
Yes. Thank you. So, respected panelists of today's session and all the participants, good evening. As I am the last speaker of this session, I think everyone must be tired by now. So, this will be my small effort to keep you awake for the next 8 minutes. I will try my best. Okay, so let's start with some pictures. This is a young boy, so full thickness eyelid injury with skin laceration. There is another picture, avulsion at both medial and lateral canthus. Another picture, avulsion at medial canthus with canaliculaar injury. Here is the simple full thickness eyelid injury with canaliculaar involvement. And here is a severe periocular skin avulsion with full thickness lower lid injury. It was because of the dog bite. Is there a technical problem? Suddenly it went away. I don't know.
Yes, I think you need to reshare.
Yeah, I think it's okay. Yeah. So from all these slides, so what we understand from all these slides. So this injury can be of variable types, and they don't adhere to any anatomical landmark. So assessment of injury is very important. We have to assess first if there is any life-threatening condition associated or not. We have to see the extent of injury. We have to see whether it is full thickness or partial thickness, whether there is any foreign body present or not. What is the condition of the globe, if it is ruptured or intact? What is the condition of the orbit, any fracture present or not? And we have to consider, of course, the vaccination, maybe rabies or tetanus, etc. So planning is very important. So if you don't plan properly, you may come out with, you may end up with such a devastating outcome. So every periocular injury, we should plan first how we have to repair that. Sometimes we get only the partial thickness injury, and these are comparatively simple. We have to clean the wound properly, respect skin tension lines, deep tissue repair first to be done by 6-week Vickrell, then align the anatomical landmark. And the important thing is we have to maximize the horizontal tension, and we have to avoid or minimize the vertical tension. Full thickness eyelid injury, this is a complete disruption of anterior and posterior lamella. We have already learned a lot today from this session. The important thing is what we have learned is margin to margin apposition. What usually I do, I first pass the my first incisions, first suture to the Mimoman orifice, then the second to the lash line, and the third one to the gray line. Whatever the surgeon to surgeon, the technique may be varied, but margin to margin apposition is very important. Here is a picture. You can see there is a full thickness injury medially and then some tissue loss laterally. So the direct apposition was done medially, and then the lateral portion was reconstructed by tensile flap. So here you can see, if not well apposed, it ends up like this, something like this. So this we have to avoid somehow. Lead sharing procedure, sometimes we need, already we discussed a lot today. We learned a lot, cutler beard procedure. I don't want to go details for this. Some other procedure are also there, fused flap and others. Here the child had a tissue defect in the upper lid, was repaired by cutler beard. Sometimes we come across very extensive injury, like it's a case of extensive dog bite injury. And when we cleaned, you can see there was this big skin gap, and there was also avulsion at the common canalicular end that we have to repair by canalicular intubation. And then the rest of the skin gap we have to repair by rotational flap like this. And finally, the outcome was, I think, not bad. So periocular injury repair should be prompt, and if we fail to do so, there would be post-traumatic eyelid deformity. Different type of deformity, like that might be canthal dystopia, maybe ptosis, there may be malapposed wound leading to ectropion, entropion. And what we see, this type of when malapposed eyelid deformity, we have to follow some principle, like we have to intervene the lesion as early as possible. We have to rule out if there is any bone malapposition is there or not. We have to release the scar. We should not keep any tension on the eyelid. Sometimes tightening of the eyelid is required, like lateral tarsus strip, horizontal lid shortening, etc. And rest we have to reconstruct the wound. So mostly in our practice, what we see that malopposed wound causes abnormal scar leading to cicatricial atrophy. So we need to release of this scar and reconstruction. Various procedures of reconstruction already we have learned today: free flap, maybe free skin graft, Oculoplasty, rotational flap. So this is the boy with the upper eyelid cicatricial atrophy corrected with the free flap from forehead. Then sometimes we need the free skin graft. This unfortunate boy presented to us with the burn on the right side with cicatricial atrophy with the corneal scar. And then we released the scar, and then the gap was managed by free skin graft, and ultimately he was doing fine. This is another case managed by free skin graft. Is this acid burn case? Sometimes we need rotational skin graft. We need to repair this cicatricial atrophy here. That was the horizontal shortening was done lateral, and the gap was filled up with scar with the rotational flap. But here is the scar is little bit thick, so we put injection as sub scar injection of triamcinolone acetonide. Sometimes we have to go for Oculoplasty, like in this girl. You can see the vertical scar just pulling the eyelid below, and in this case we just tried multiple flap Oculoplasty, and the scar was released, and we broke the scar in this way, and the lid was in position. Eyelid margin was in position. So for any canalicular injury, the canalicular trauma is always associated. Our previous speaker, Dr. Diva, she explained very nicely the monocanalicular injury, bicanalicular injury. There's might be a I don't want to go details for this, but we have to take care in case of any laceration in the medial canthal area. We should be evaluated for canalicular injury. We have used different materials so far, like silicone rod, DCR tube. We have used even pano cannula, but now we are using mini monoca stent. Just I want to share one of my experience with Dr. Diva. She said that keep this mini monoca stent for 3 months, but in my practice, we usually keep for 4 to 6 weeks, not more than that, because it usually takes 3 weeks for recanalization of the canalicular, and if we keep it for a longer period, then there is a chance of granuloma. So here are other experts. I think we can have some comment from them as well. Sometimes bicanalicular injury repair needed, canalicular intubation required. Sometimes we do by upper and lower monocanalicular stent, mini monoca stent, or sometimes Crawford tube intubation is also required.
1 minute remaining, please.
Yes. So key message is all these patients needs proper referral, proper assessment and planning, and timely intervention is very important. If you are delayed, you may not get the proper outcome. Material repair with margin to margin alignment is very important. It gives us good cosmesis and maintain function. I'm very much thankful to the organizers and everyone for giving me chance to this wonderful webinar. Thank you very much.
Thank you, sir. It was indeed an excellent overview on the trauma of periocular region. Now I would like to invite Professor Dr. Tayyab Afghani, sir, for the comments, please.
Thank you very much, Dr. Nuruddin. I think it was a lovely presentation. I've already gone through it yesterday when Ben sent it to me. There is nothing much to add, but just I wanted to say one, just give my comments about, we come across sometimes these, some of the injuries come very late, these periocular injuries. And we have come across certain occasions where there is malunion. I mean, let me put it like this, that there was a avulsion of the eyelids, and then they just delayed, or they just did not present it properly. And then what happened is that the part of the lower lid was attached to the upper lid, and when the child or the patient presented to us, it was a sort of lower secondary glaucoma, secondary coloboma of the eyelid, and upper lid was lengthened. So this the important message is that we have to look at the patient very thoroughly before, and then otherwise this could have been missed. and we just took the additional piece from the upper lid and then attached it to the lower lid. So this have to be seen. That is the first point. Second point is sometimes the periocular trauma takes place in areas, of course, where there are not specialist services available, and there is primary repair is done not meticulously or in an organized manner. So there is a problem that when it comes to us, if it comes within 24 hours or within 48 hours, we have to reopen it, dismantle the whole repair done earlier, and then reorganize and reconstruct it. So these are the 2 points which I wanted to add to the Dr. Nuruddin's presentations. Otherwise, perfectly fine. Thank you very much.
Thank you, sir, for the comments. We are delighted that today's webinar has garnered a lot of interest as evidenced by the number of participations through our Zoom link, Facebook and YouTube channels. And thus there are a lot of questions too. Due to time limitation, we will select only few queries, and the selected queries will be discussed with the panelists in our next session. And that session will be panel discussion session. And to moderate the panel discussion session, I would like to hand over this platform to Dr. Ben Limbu. Sir, please.
Thank you, Ashish. Thank you very much. Now we actually have come to the last session of the whole webinar, and then there are a few questions that have raised in question and answers forum. I'd like to read one of that. It says, do you apply topical steroid in mammary gland dysfunction, or you just apply, you choose either tetracycline or any steroid that is mixed with antibiotic? So I'd like to request our other panelists to answer this question.
I think Samira can add some enlightenment in this matter on your management parts. Whatever the steroid or steroid with antibiotic.
Okay, thank you very much, sir. Doctor, this is a problem which is not going to go away in say 1 week or 2 weeks. It's going to stay for 6 months or 1 year. So the treatment has to continue, and unfortunately, you cannot give steroids for such a long time because of the complications. So what I found in the previous years that cyclosporin, tacrolimus, we get tacrolimus as skin cream, and we use it in the eye, which is 0.03%. It's absolutely safe and it is amazing. Then acetylcysteine, all these three have a marked anti-inflammatory effect. They reduce the bacterial load and they reduce the angiogenesis, which is a part of acne and other problems. And they reduce the inflammation a lot, improve the secretion of meibum. So these three, these are important steroid-sparing drugs, and they should be used rather than steroids, because you can give it steroids initially, say for a week or 10 days, and that's it, if there is a lot of inflammation. But I personally don't like to introduce my patients to these. I like to be safe. And I have found that all these three, cyclosporin, tacrolimus, and acetylcysteine, they are amazing drugs. At any age, in any age group.
Yeah, thank you, Dr. Samira, for that wonderful sum up. Do you have any experience of using oral antibiotic for patients with mammary gland dysfunction? How is your experience on it?
If it's the problem is say grade severity grade 3, it's a cheesy and a lot of frothing, then of course oral tetracycline has to be given for 6 weeks, a course of 6 weeks, 100 milligram capsule one daily after breakfast for 6 weeks. If patient is allergic or some problems are occurring to tetracycline, then a course of azithromycin, one tablet 250 milligram 3 days and for 3 consecutive weeks. 3 days, twice a day for 3 consecutive weeks, then azithromycin. But it's not as good as tetracycline, which are given for 6 weeks. So, yeah, you have to add that.
Thank you, Samira, for your explanation. I do use doxycycline for 6 weeks or even longer, starting with a twice daily dose for the first 2 weeks, followed by once daily for at least 4 more weeks. And if I use azithromycin, I'm using 500 milligram daily for 3 days, repeated every month for 3 months. That's the dose that I am following. And I always use a topical low-strength loteprednol for the first 3 weeks, starting with thrice, tapering to twice and once, till the effect of the other anti-inflammatory that you spoke about, the cyclosporin, or cyclosporin, unfortunately, is available in very low strength in the market, so it doesn't really help that much as the loteprednol does. So I'm using loteprednol later if required, but I do usually in many cases start with a low strength loteprednol.
Yes.
What about the use of artificial tear? This is also important combination here.
Yes.
Thank you, Oculoplasty, for that wrapping up with the oral medicine. I have another query in my mind. This is not from our audience, but there are certain patients who have a lot of swelling in the eyelid with MGD, and then who have been biopsy, and then it shows it's just inflammatory disease. It doesn't show any malignancy. And patient keeps on coming. They are young patients, and they keep on coming to our clinic with the bumps, a lot of bumps around the eyelid margin, close proximity with the meibomian gland. So, how do you proceed with those patients where they keep on coming with small myomyitis and swelling around the meibomian gland opening? What is the suggested treatment for those who recur again and again?
You have to educate them to squeeze, to apply hot fomentation, to massage it upwards, to release all that pent-up meibum. What happens is the meibum gets collected in the ducts, and then a fine membrane forms over it, and those lumps and bumps, they are actually oil-filled. So you have to remove them, you can wipe them off, and then educate them to squeeze and empty them daily. If they are, what happens is like toothpaste, you open the cap, leave the cap open, the toothpaste, the top gets hardened, and because of evaporation. So that hard top, it's a blocked duct. And you can then the meibum is very hard. So with a hot needle, say if there are many glands that are blocked with that hard meibum, then probing has been. You can do the probing, and that you can heat up the handheld pottery, heat up the needle a little bit, and then just melt the plug, and the meibum comes out.
Thank you, Dr. Samira. Thank you for that. And there's another question. Is it safe to use mascara by the ladies?
Very bad.
There's a question.
It's the makeup, the powder, it gets blocked. So I tell them to apply upper lid outside, never in the.
You don't recommend them to.
Not in the lower lid, never.
Oh, okay. Okay, thank you. And there is another one question that I want to raise here by our viewers that asks whether to do. It's not from our presentation today, but because I think Basanta sir has shown up the retinoblastoma report. There is a question on retinoblastoma, whether it's safe to do a CT scan or MRI, or choose one, which is preferred one. So in my opinion, for the poor patients, we have to consider the cost. So considering the cost, the CT scan I prefer for unilateral cases, not for the bilateral cases. For unilateral cases, I prefer CT scan not just to see the calcification, but also see if there is any secondary tumor into the brain, because the prognosis and treatment vary if the tumor is into the brain. We just want to see not only the calcification, but also the laterality, and also to see if there is any intracranial extension. So I prefer CT scan for unilateral cases. For bilateral cases, almost MRI I prefer, because there is chance of second carcinoma, second carcinoma with exposed to CT scans. So I believe I do the MRI for all my bilateral retinoblastoma patients. But the question is again open to all the panelists if you have any good answer to say to our viewer. Thank you.
About the CT scan,
yeah,
because retinoblastoma, the journal of many textbooks written that CT scans should not be done under 5 children having retinoblastoma because for secondary malignancy. So MRI is preferable under 5 children with retinoblastoma or any malignancy in children, sarcoma. Do MRI choice.
Yes, sir. MRI, because it will prevent the secondary carcinomas to the children. That is the one reason, yes, sir. Is that the reason?
Yes, Ben. I think wherever patient can afford, the MRI is generally now used as the first modality only for the fear of the radiation that we are giving to the children. Maybe not just once, but sometimes on a repeat occasion also. So that's why it's usually.
Not only, not only because of fear of radiation, but also because of, we know that, of the staging of retinoblastoma. It's very important that its MRI probably should be essential for all cases of retinoblastoma because it helps in thickening of the optic nerve and the involvement of the optic nerve and other tissues. That's very important for prognostication as well as for staging retinoblastoma. So I think there should not be any alternative to MRI. We should arrange MRI for all cases of retinoblastoma.
Thank you, sir.
I have comments on Sruti's presentation. So Sruti, you are there, I guess. You do not believe, you don't believe on radiologists. You just listen there. Yeah. In both of your cases.
Always work together with the radiologists.
Yeah. So in both of your cases, they just mislead to you. Look where they've drawn you. Yeah?
Well, they did not mislead me, but after discussing with him, what they said was, in the initial phase, when it is actually quite misleading if the wooden foreign body is too tiny. Because if it is large enough, you can see a radiolucent, a blackish image, which is something like you can probably in the same color as the fat. But if they're very fine, you can actually miss those, and the end-on view of it will appear either like a vessel, or it will be which will be like air which is entrapped. So he was like, and also because when the wooden foreign body, what he says is, if it is in the orbit for long, it induces some kind of a reaction, and then the fat, and the blood and the granuloma which forms inside can give a false interpretation of a tumor which is vascular.
Yes, I agree that. Again, come to the MRI versus CT scan in your cases.
Yes.
So all the objects which are radiolucent, like wooden pieces or this piece of glasses, they are much better elucidate in the MRI, because you know that CT scan cannot give detail of the radiolucent objects which can give by MRI. That's why. So when we ask this radio investigation, I always try to get film first rather than the reports, because some of the radiologists are very much familiar with the ocular radiology, but some are the beginners. They just write the that very surprising things. That's why we have to listen them, but do not believe. And I would like to ask Dr. Naresh. I think Dr. Naresh is here. So you are not doing huge flap for last 15 years. Surprisingly, I would ask why. Because huge flap is one of the very lovely procedure, and most of us are doing for many years with very good result. If there is a chance of obscuring the vision in the huge flap, it can be modified by taking the hinge at the side medially or laterally, which was modified by Eva Hewe flap. The same thing, but here the visual axis is clear for the one-eyed patient or the patient who need the regular topical, like anti-glaucoma drops like this. So these are the fantastic, but you are choosing not the huge or heaviest flap, you are choosing some other alternatives. Can you make some remarks on this, sir?
Sure. What is the Hughes flap good for? Well, the Hughes flap is very good for long, shallow defects. It is not good for deep defects, which is better with cheek mobilization. So the nature of the flap is to reconstruct shallow, long defects. That's what it was made for, and that's what it's good for. In my opinion, shallow, long defects of the lower eyelid can be left completely. So if you have a possibility of not doing anything and getting as good a result, why would you do something that can compromise the upper eyelid? That's my only question. Of course, it's a great operation, but the one thing you have to do always is to step back and say, if I don't do it, will the result be any less? So if the result is comparable without doing anything, then why do it? That would be my first argument. The second argument is, if you look at your Hughes flap really well, diligently, almost all Hughes have a mild malposition of the upper eyelid. It's not just a closure element. So you will retract and you will change the configuration of your upper eyelid and the conjunctival surface of the most important structure of your periorbiter, which is your upper eyelid. The upper eyelid is the most important structure. You can live without your lower eyelid, providing those parameters are obeyed, which is normal corneal sensation, good upper lid, and a good bells. So the question you have to ask yourself always, and I've done so in my 25 years, is, can I do less? So similarly with hard palate graft, can I use something alternative, like a mucosal graft? So every question you have to ask, do I need to do a tarsal strip? Do I need to shorten the eyelid? There is so little evidence. We know we have a preference. We have really good data as to what really works and what doesn't work in surgery. So I think for every young person, they should always question what they're doing. Is what I'm doing the best that it can be? Of course, the Hughes flap is great for reconstruction, but the question you have to ask yourself is not, is this a good flap, but should I do it? That's the question.
Dr. Norris, I will draw one more time of you. So here, all the cases are so bloodless surgery. So how do you secure such a fantastic hemostasis in oculoplasty?
Well, I think, every step is important. I think I've operated with you, Rohit, in Nepal. I say you need to think about every step. How do you optimize each stage? So, from making sure the patient has done all the things that they should, no aspirin, etc., choosing the right anesthetic, choosing the amount of adrenaline, injecting in the right place, always using hemostatic techniques along the way, just gives you that chance. But I think, it doesn't really matter. It looks great on presentations, and that's just my personality. But the outcome, even if it bleeds a little bit, doesn't really matter. The question is, if it bleeds so much that you cannot identify the anatomy and you compromise the result, then that's not good. If it bleeds a little bit and it doesn't look so good on photographs, that's irrelevant. So, of course, I'm doing this partly because it's my obsessive compulsive nature, but also because it helps with teaching. When I teach, of course, if I can show you every layer, then it helps hugely. So when I do the flaps and things, I'm trying to do it in such a way that when I'm teaching, it helps to show the vessels, etc. But it's not that necessary. But thank you very much for allowing me.
Before you go, Shruti had a question for you about medial canthal fixation. Shruti, would you please ask the question that you wrote on the chat?
Dr. Kadesh, for all the medial eyelid avulsion that happens, do you always use mini plate and screw and fix them?
No. If you have any remnant of tissue that you can fix it on, use that. Your own tissue is the best. If you, any additional hardware, is a complication. The key to any reconstruction, as I see it, or lack of reconstruction, is simple things are best. I mean, that's why I have gone from more complex flaps, less complex flaps to nothing. If you can wait and see if things will get better. That's the thing about reconstruction. Of course, you can't for the upper eyelid, and of course, you can't for exposure keratopathy, but you can wait. And so for the medial canthals, if you have a remnant of tissue that you can fixate on, well, please use it. Mini plates, Mitec screws are only if you have nothing left there.
Yeah, because invariably when there is an avulsion injury, when we are trying to anchor it deep down to the lacrimal crest, the bone is so thin that you can't really take a bite.
Yeah.
So that is when we have the problem of where to fix it.
Yeah.
Naresh, who makes the Mitec screws, those that you showed?
I beg your pardon?
The Mitec screws that you showed, who makes them?
You know what? Actually, it is in my presentation, the name of the company, but really the advantage of the Mitec screws, which is incredibly expensive, is that it comes with a drill bit. So it means that when you make a drill hole and you push this thing in, it locks automatically and it gives you 2 stitches with hooks, with needles. That's the only advantage. But you need good bone, that's the key. But if you have good bone, you can just put a plate. You can just put a two loop plate, which is much cheaper, of course.
Yeah, we often need to put in those micro plates and use them.
But no, my thing, as I'm coming to the end of my time, is always to look back and say, can I do less? Will it be as good? Question everything. That's what I would say to everybody. Don't always take everything that you're taught, because things are passed on and on and on. You have to question everything. In my practice, as I'm doing it, is this the best that I can be? Do I really need to do the reconstruction? It's actually very difficult not to do the reconstruction sometimes, but that may be the right thing.
Thank you, sir. So I think if there is no any other questions, we want to conclude the question and answer sessions and panelist session by now. And then we'll move forward to the last program of the webinar. I request our moderator to continue the program.
Thank you, Dr. Ben. It was nice to listen to all the mentors for their views on different techniques. Thanks a lot. Now we are near to the end of our program, and I would like to invite Dr. Ben Limbu, General Secretary, Nepalese Society of Oculoplastic Surgeon, and Scientific Secretary of Oculoplastic Society of South Asia, for the vote of thanks.
Thank you, Dr. Prerna. First of all, I would like to thank Dr. Ashok sir and Dr. Basanta sir for their continuous encouragement to make this webinar a possible dream. Similarly, I'd also like to thank all the speakers who have really enlightened us with their cases, and then also a wide horizon of knowledge that they share with us. At the same time, I'd like to thank Dr. Naresh Joshi sir, who gave us time for the webinar to be a guest orator for the program, and he has really highlighted, and also he is the key person for the whole program, that I think that with all his knowledge and experience that he has gathered, backward and forward movement of his techniques. So we actually learned a lot from his talk. Similarly, I'd also like to thank all my panelists, including Dr. A.K. Grover sir, Dr. Basanta Sharma sir, Dr. Ghulam Haider sir, Dr. Tayyab Afghani sir, and also all the speakers, especially from the SAR, Dr. Murtuza, Dr. Samira Irfan, and similarly Dr. Shruti Tara, and all my colleagues, the younger generation colleagues who are shining like a star in front of this international forum. I'd like to congratulate all of them, and also thankful for all of them. Apart that, to make this program, we need background support for the logistic, for which Sun Pharma Nepal has done their tireless effort to manage all the things. So I'd also like to thank at the background Sun Pharmaceutical Company to sponsor the whole webinar. And also I'd like to thank all our audience, all national and international audience who have viewing our webinar. Since it began, we have more than 270 participants viewing our webinar right now, which I think is a proud moment for us. And I think thank you everyone for making this event a successful event. Thank you very much.
Thank you, Dr. Ben. Now I'd like to invite Professor Ghulam Haider Sir, General Secretary of Oculoplastic Society of South Asia, for the closing remarks and announcement and end this session.
Mr. President, Oculoplastic Society of South Asia, and President NESOS, Professor Ghulam are actually our guide. They guide us all the way from the beginning. So we form the academic calendar all over the year. So our next webinar at Pakistan, 3rd January. Then next 3 months, India, then Bangladesh. Then 7th November 2021, 4-day program is going on, will be going on. This is the information for all of you. Now, OPSSA member increasing day by day. Now 30 members till now. Our registration process is going on, though a COVID process may deal the delaying process for registration. We're trying a lot. So I think all of you should be a member of OPSSA. Thank you, all of you.
Thank you, sir. Now I think
thank the organizers once for an excellent meeting and creating an excellent template for our future meetings. On the basis of this, we will share a template for all future meetings. I think you have done it exactly as we would like it to be. Maybe we can have a little more discussion from those other than moderators in those 4 minutes. I think we may consider other modifications based on your feedbacks. We'll request all of you to give your feedbacks based on this program. And we very much look forward to the next get together with Pakistan Oculoplastic Society. But thank you, Nepal Society, for creating a wonderful, wonderful program which brought us all together. Thank you. And thank you, Secretary of the OPSSA and the organizers of the Nepal Oculoplastic Society.
Thank you, sir. Now, with the permission from two president, Nepalese Society for Oculoplastic Surgeon and also Oculoplastic Society of South Asia, would like to conclude the end of the webinar. Is that okay, sir?
Please go ahead. Thank you very much, everybody.
Thank you very much.
Wishing you all a happy festival. Stay safe. Thank you all.
Thank you very much.
Thank you, everyone.
Bye-bye.
Thank you all. How many everyone? Last to join. Last to join.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Bye-bye.
Well done.
Thank you, Ghulam, sir.
Wish you well done.
Yeah.
And the president.
Thank you. Bye-bye.
Thank you.
अरू कुरा पछि गर्ने है थाक्यो
President, thank you very much.
Thank you, sir. Thank you for your cooperation. Yes, this was the first time for many of us, so the little bit of we were having some ups and downs, but I think next time we all of us will do much better. Yeah, and then yeah, but we really have to fix this IT business. There's a lot of
Dr. Basant, this is a well organized. This small turbulence even happened in Singapore.
Yeah.
That's why looking at this is not dependent to us. So
Yes.
overall, I see this is very well organized, and our new this anchors, Prerna and Ashish, well job, and our presenters, Malita, Diva, and who else? Home. Yeah.
Home.
Now, yeah, they have lunch. They have lunch in the international program, so they should continue this journey, participating more and more. Wherever you get